was not explained very well. Instead of taking, as required, was taking less dose by 100 milligrams. And also, the persistent non-viral suppression probably is contributed by drug-drug interactions between the amphibians and the ARVs. Next slide, please. So this one is showing the most recent drug resistance results that was released on 30th of July this year, whereby it indicates the different classes of antiretroviral drugs. If we look at the integrase strand transfer inhibitors, we realize that all the drugs on the list is showing already a high level of resistance, including the dolutegravir, which the client is currently on. And also, if we look at the non-nucleoside reverse transcriptase inhibitors, almost all also showed high level of resistance, except etravirine, which the client is on, which indicated intermediate level of resistance. Next slide, please. If you look at other classes like the nucleoside reverse transcriptase inhibitors, the client is on lamivudine and also tenofovir. And actually, in all these classes, among these examples, all of them was showing high level of resistance. And among the protease inhibitors, also almost all the drugs on the list indicated high level of resistance, except the last two examples, that is the saquinavir and the tipranavir, which indicated intermediate levels of resistance. This was the drug level resistance result for this year. We also have for last year in the subsequent slides. Next slide, please. This one was released during 2023, September. And also the patient had results showing resistance in the different classes. If you look at the integrase strand transfer inhibitors, it was showing high level resistance to bictegravir and cabotegravir, although the client is not on it. There are other examples in the subsequent slides under integrase strand transfer inhibitors. If you could look at the next slide. So still under the integrase strand transfer inhibitors, we have the dolutegravir, which the client is still currently on. During 2023, it had shown already high level of resistance. Then among the non-nucleoside reverse transcriptase inhibitors, all the drug classes indicated were susceptible, and probably that's why the patient was added etravirine during 2020, after the result for 2023. Next slide, please. If you look at the nucleoside reverse transcriptase inhibitors, the client was on tenofovir and lamivudine, and during 2023, they were all susceptible, including other examples under the NRTIs. Unfortunately, I could not see the result for the protease inhibitors from the patient's file. And next slide, please. So we had shared this case with the regional team, and we had come out with a recommendation to temporarily maintain the client on the current third line regimen, that is the tenofovir, the lamivudine, dolutegravir, etravirine, darunavir, and ritonavir, as the case needed to be presented here as it's happening today, in order to find out what is next treatment plan, which is best for our clients. And also, the client is on anti-TBs, as mentioned earlier on, and also the client needs to find a proper treatment supporter, which is a big challenge currently, and also needs attachment to young and adolescent peer supporter to encourage retention and adherence to the medication. And also we request for advice concerning the combination of anti-TBs, rifampicin, and also with other ARVs like darunavir and ritonavir, as the dose had remained the same except for the dolutegravir, which was doubled. That was the end of the presentation. Thank you so much for listening.
Thank you, Dr. Emmanuel Odong. That case was quite exciting, thank you. It has highlighted the social challenges we have and how these challenges with taking ART. Whoever has any questions, comments, kindly write them down and we'll have them answered together with Dr. Jen when that time comes. But the next speaker to us is going to be our ED, Dr. Sise Mutuluza Chitio. She's our Executive Director, Joint Clinical Research Center, and the Director of JCRC College of American Pathologists, CAP, Certified Laboratories. She's a very experienced medical doctor, a vaccinologist, and public health expert for over 27 years. She has a lot of experience in conducting and coordinating AIDS research and care in Africa. She's one of the pioneers of in prescribing ART in sub-Saharan Africa. Her interests are mainly in clinical research and cell and gene therapy. Actually, she's the founder of the Global Gene Therapy Initiative, GGTI, which was formed to tackle the barriers to low and middle income countries' inclusion in gene therapy development. And she's working with various stakeholders to identify and address key areas that are requisite in successful implementation of gene therapy in developing countries. We've just concluded the first symposium actually on this. She's the PI for the Gilead Sciences studies, and she's also a co-PI for the SCTG studies network at JCRC. Please welcome Dr. Sise to the podium.
Good afternoon, everyone. Hope you didn't have a heavy lunch and are now starting to doze. So there was a bit of mishap, but I'm here. And thanks to the organizers for inviting me to present on long-acting antiretroviral therapy. And I think this has a role in the case study that has just been presented. And I will give a brief overview of what we are doing at the JCRC with regards to long-acting ART and what the implications are for low and middle-income countries. So, long-acting ART is already registered in the high-income countries, in the US, in Europe, it is being used. But of course, prior to this, there were studies, registration studies, that led to the registration of these drugs in high-income countries. And the main studies were called FLAIR and ATLAS. These demonstrated that taking long-acting injectable cabotegravir plus rilpivirine every 4 weeks was equivalent to taking your daily pills. And then following on to that, there was the ATLAS 2M, which demonstrated that, and 2M means it was being given every 8 weeks instead of every 4 weeks. It demonstrated non-inferiority of that regimen to taking oral pills every day. So based on those studies, the injectable long-acting cabotegravir and rilpivirine were registered in US and Europe. And now they are actually implementing. They are giving these drugs. There is a choice for people to select if they want to be on that. But there is, and there was still a big gap by the time we started the CARE study. They had not compared the 8-weekly to daily oral standard of care, which we have done in the CARES. And also the evidence to determine the role of long-acting therapy was needed in treatment programs like ours, where we have a public health approach. And there are many things that are different from the West. So the FLAIR, ATLAS, and ATLAS 2M were done in those countries. There were a few patients from South Africa, but you all know that the population that is in those countries is not generalizable to low and middle income country settings where we use the public health approach. There are several differences, including background resistance to NNRTIs. And we've had prior episodes of using efavirenz and nevirapine. So this is widespread. That is why we actually moved to TLD, because there was a lot of resistance in the background in the population. And we've also used nevirapine for some time in the past, where we used it for mother-to-child transmission. Our virus subtypes are different. In the high-income countries, it's subtype B. And what we have here is subtype A, D, and C, mainly. Then we have comorbidities. I think you heard from the case presented, TB. And then the use of rifampicin and also drug-drug interactions. The regimens we use for standard of care mainly now is TLD. And this is not what they use in US and Europe. And then, of course, the majority of the population affected by HIV here is Black African women. In the West, it is mainly men. And the care and treatment strategies are different. I think you're doing one viral load a year. Safety monitoring may be very minimal. But so, for all these reasons, there was justification that we do a trial in our populations to inform policy and practice. So that brought about the CARE study. CARE stands for cabotegravir and rilpivirine. Those are the two drugs that are given by injection, efficacy and safety study. So the hypothesis was to determine if these two drugs, with all this background of resistance and subtypes and everything, was non-inferior to the standard of care. And we looked at viral load as our endpoint, which was below 50 copies at month 12. And this was compared to the standard of care which was there at the time. There were still some patients who were still taking efavirenz or nevirapine. They were allowed into the study, but the majority was taking a dolutegravir-based ART regimen. So very quickly, these were the objectives. We wanted to look at efficacy. We wanted to look at safety. We wanted to look at viral drug resistance in the participants who failed or who had confirmed virologic failure. And we also wanted to look at perspectives of the participants, of the healthcare workers, in terms of what did they think about long-acting ART. The additional objectives included looking at hepatitis B reactivation, and I will explain why. We were supposed to have a health economics sub-study, which we didn't do. And then we've also collected DEXA. We've done DEXA scans and collected data on body composition, and this will also be analyzed and compared between the two groups. So this was the study design. We recruited participants who were above 18 years of age. They were on stable oral therapy. They were either taking DTG-based or efavirenz-based regimens. They were supposed to be virologically suppressed with a viral load below 50 and with no history of treatment failure. And they also were not supposed to have hepatitis B infection, so we screened for that. They were randomized to either stay on their standard of care or to go to the injectable arm. And for the injectable arm, it was also optional. You took an oral lead-in, which was tablets of cabotegravir and ribavirin. We followed up total the participants for 96 weeks, and we did a viral load every 6 months instead of every year, because this is research. But in the West, in the registration trials, I think they did the viral load maybe every 2 months. We could not afford that. And then we also took cells, PBMCs, at baseline, and we wanted to look at archived resistance in this population, and also the HIV subtype distribution. So I've already mentioned we did viral loads every 6 months. And I've already also talked about cells that we picked from baseline so that we could look. These were participants who were virologically suppressed. So for you to be able to measure the drug resistance, you have to use the cells, because patients archive these resistance. Even when we change the regimens, like in the case study that was presented, the mutations are archived and you can find them. So that is what we wanted to see in these participants. And then our primary endpoint was at week 48, which we already reached. And I'm going to give you some of those results because we presented them already in an international meeting at CROI. But we've also completed the 96 weeks of follow-up. We completed that in July. And currently we are doing analysis, and we will be presenting an abstract to CROI again by 9th of January. So with regards to the outcomes and analysis, I already said we looked at viral suppression after 48 weeks, which was viral loads below 50 copies at week 48. And what we use to analyze is called an FDA snapshot. This is very commonly used in all international studies. And we use the intention to treat population. Anybody who took a dose of the study medication was included in the analysis. And we used a 10% non-inferiority margin. And then we also looked at the secondary objectives, safety, and then treatment satisfaction. So we, at the start, when we had approval to do this study, we selected sites. Some of the sites were selected by the funder themselves, but in Uganda, we did select ourselves, of course, at Lubowa, and then we also selected our Regional Center of Excellence in Fort Portal, and then Infectious Disease Institute was one of the research sites. And in Kenya, we had Aga Khan. Then we had Moi University, which is in Eldoret, and then Kemri, which has a site in Kericho. In South Africa, we had a site in Durban, which is part of the South African Medical Research Council, and then we had Ezintia, which is based in Johannesburg. And up at the top are the different principal investigators for these sites. So we started screening in September 2021, and that's when we had the first participant in. The first participant was in Fort Portal, and everybody in Fort Portal has already upgraded their CVs as the people who did the first injectable ART in sub-Saharan Africa. We took 12 months to recruit across all the sites, and then the first participant, we started exiting them 17th July last year, and by 3rd July this year, everybody has completed the follow-up of 96 weeks. So again, that is the, on the left-hand side, the sites and the proportions of participants that were enrolled from the different countries. The South African, one of the South African sites failed to enroll their allocated number, and so we divided them between Uganda and the other South African site. That's why the percentage of the contribution is lower. On the right, you can see that we had excellent participant retention, 99% after 48 weeks of follow-up. Then I already said we have completed the 96 weeks of follow-up, but I don't have the results here. Again, retention in the study was very high, 98%. And you can see we had 527 participants who were excluded from enrollment into this study. And 400 of those was because of hepatitis B. So hepatitis B is quite frequent. And for some of them, they did not have surface antigen, but they had a core antibody test was positive. So they were excluded. And for those that were excluded because of that, we did additional analysis to see if they had surface antibodies that could have protected them from getting flares of hepatitis. Because remember, if we are taking you off TLD onto injectable, which does not have NRTI that is effective against hepatitis, then there is a risk. And we found that most of them had fairly high antibodies, and they would have done well, but we excluded them anyway. But this is important because if we come to implementation, in a population which has very high hepatitis, we have to be careful, and we have to have algorithms on how we do screen or get participants into the study. So this is the baseline characteristics. We had more females in the study. We had people who are obese, 21.1%, which is fairly high. And of course, most of the participants were black race, except one Indian from Durban site. And then these participants had been on ART for a fairly long time, median 8 years. And previous exposure to NNRTI as expected was high, 74.2. At time of screening, the majority, 92, were on TLD, and that was also expected. We started in 2021, when rollover, I think, started in 2019. And then at the bottom, we have archived resistance. Although I say baseline, this was only done retrospectively. So we did not have those results at the time we were enrolling these participants. So we found very high levels of reprievrin and cabotegravir resistance, as you can see from those numbers. The majority of the participants had subtype A1. So we looked at adherence and timing of injections, because this is also a worry about rolling out. Are people going to come on time? Then what happens if they don't come on time? But this being a study with a study team and calling and reminding, as you can see, we had very high levels of adherence to the timing. The timing was 7 days or 7 days before the actual date you got the injection, or 7 days after. And the majority of the participants complied. So these are the results. The summary of the results is that we did not find any difference in viral load suppression between taking injectables and staying on the standard of care that patients were taking. And remember, this is in the background of high levels of NNRTI resistance, different subtypes, high levels of obesity. So we are this was presented at CROI in March. This is a big meeting that takes place in the US. And this was actually the highlight of the CROI meeting this year. This slide just shows the non-inferiority that I talked about. We set a margin of 10, and this falls within that non-inferiority margin that we set. We had 2 participants with biologic failure, and on the right, one of that participant actually died soon after week 48 from post-surgical complications, not from the trial. And then the one on the right did not have, because it's been shown in the West that the predictors of failure include obesity, they include presence of reprievrin resistance, and there are 3 predictors mainly, and a publication has been and subtype, which is subtype A1 or stroke A6. And we find this participant did not have obesity. Their baseline BMI, the one on the left, was 25.9. Subtype was A1, and they did not have any baseline reprievrin mutations. So looking at safety, of course, if you look at the line where you have grade 3 adverse events, these were similar between the 2 arms. So injectables were safe. And then because this is injections, the most common adverse event we saw was injection site reactions. That was, the commonest was pain, of course, but this pain lasted only 1 to 2 days. There was only 1 participant with grade 3 injection site reaction. This was a nodule, and where we were giving the injection, and this participant had to be switched because the nodule was not resolving. So we looked at treatment satisfaction, and you see at baseline, there is no difference in the satisfaction between the two groups because they were all on oral. Then at week 48, we implemented a questionnaire, and you see there is significant difference in satisfaction, much higher for those participants who are on injectable compared to the oral. But besides this, we also saw, we got many calls, many people coming and wanting to be given injectable. But the injectable was not available because it was just within the research project. So in summary, the conclusions from this CARES trial, we saw high efficacy. We saw a very low rate of confirmed biologic failures. We had a very good safety profile, and we saw increased treatment satisfaction. This treatment satisfaction has also been seen above, the measures were different, but it was very high also in the registration trials that I talked about in the beginning. And I would like to, of course, acknowledge the trial participants. Without them, we could not have done this study. The sites that were involved had many teams that were working on this. Ivan here was the project coordinator, and then Nick, who is based at the MRC, was our scientific advisor, but I'm sure there are many people in this room who were part of the CARES trial. And we thank you, but also congratulate you for how far we have come. So without funding, we could not have done this study. So we thank Janssen very much for taking that leap of faith and trusting us. The JCRC was the sponsor, coordinating center for this trial. And for you who are in research, some of you always hear the sponsor is either in the US or in Europe. So this was, like very strong trust, and I think we did not, we did not disappoint. We also had oversight committees that were supporting us, and the trial steering committee was headed by Professor Kalebu, and then the Yunus is from South Africa. He's not from the Europe. So it is basically Africans leading this trial. We also had an independent data and monitoring committee, which was led by Sam. Sam is based in South Africa, and then Paula is a Ugandan, and Andrew is based in UK, but he's been part of many clinical trials across the world. So this was the sponsor team at the JCRC. They worked very diligently to deliver this trial, and they are still working to make sure that the analysis is completed properly and we have data that we can submit at the next meeting. So what are the trial implications, CARES trial implications for low and middle, for Uganda, for Africa, and other low and middle income countries? So we've already demonstrated, and this is a big study, it's a phase 3 study, we've randomized controlled trial. This is, like the standard people are looking at. We've demonstrated safety and efficacy of injectable cabotegravir and riprivirine, and this is the essential first step to discussing a potential role of long-acting treatment programs in low and middle-income countries using the public health approach. And again, if you remember the case that was just presented, I think this is a case that can benefit from long-acting ART. We have shown, although this was a phase 3, we have shown proof of concept that trials of long-acting ART can be implemented successfully in low and middle-income countries for enhanced access. And this may seem like small, but for some of you who were here, most of you I see are very young people, but to get ART into low and middle-income countries was a big struggle. This was oral treatment, and everybody in the West said these people, they cannot manage oral antiretroviral drugs. And it took a lot of advocacy to get the drugs here. So what about long-acting ART, which even has more issues? So that's why, although this is a phase 3, it's a proof of concept. And we've used cabotegravir and rilpivirine today, but you remember where we started with DDI, DDC, D4T, and we have transitioned to TLD. So it will be the same journey for long-acting ART. We'll start with what is available, but more exciting things are coming. There are products that can be given every 6 months. You just take 3 injections in a year and you're done. So I think we've started this journey, and I'm sure many others will join us. But also there is high acceptability, and we saw the participant satisfaction with, within the study, but also calls, and we've done the social science study, which will also be published to show what the healthcare workers think, what the study participants think, but what other people who are not in the study think. So, of course, what leads to failure, not only TLD, but to oral pills, we have, it may be obvious, but if you do not have published data, then people don't listen to you. We've already shown that we took participants who were rolling over to TLD, and we also took an objective measure, which was a dry blood spot, but we measured the dolutegravir levels for people who were not suppressing. And we found that always the levels were low, so it was obvious that there is non-adherence, and that is why we get viral non-suppression. So this is the UNAIDS report for 2024. All over the world, it shows that 72% of patients on ART are the ones suppressing. So 28 are not suppressing. Over 25 million are on treatment. So you can do the mathematics. So there is a big number of people who still have a viral load, and we know that the high viral load, of course, fuels the HIV transmission. So achieving viral load suppression for more people with HIV is essential for us to reach the UNAIDS targets. And you know those targets, 2030 epidemic control. This is a slide for Uganda. Now we come back to Uganda. We have 89% of people living with HIV who are suppressed. So 11% calculate how many we have. Over 160 people, they are not suppressed. So what are we going to do? You are healthcare workers, some of you are researchers. What are we going to do to promote viral suppression in our population? So some of the interventions, of course, are adherence interventions using low-cost measures. And some of the low-cost measures is counseling. Isn't it what you're doing in your clinics? You are doing counseling. But how standardized is the counseling across the different clinics? We don't know. But the other thing that is an innovation that is already available in the West that we should have here is providing long-acting ART, especially in settings with highest disease burden like ours. And So looking at adolescents, looking at key populations, and other populations that are not suppressing. So we as JCRC and many other people, we are all looking at a cure, because if you have a cure, then we don't have to deal with viral non-suppression. And, but we don't have a cure, we don't have an effective vaccine, and antiretroviral drugs today remain the cornerstone of HIV treatment and prevention. So the need for high levels of adherence to daily oral regimens remains a barrier to the success of both treatment and prevention. And long-acting injectable antiretrovirals have the potential to improve adherence with less frequent dosing. And so long-acting ART should not just remain with cares. We have results, they are good, and we stop there. Because it represents an important step in reaching the global target of ending AIDS as a public health threat by 2030. And this is the research and development sort of roadmap that has been happening. These trials that I talked about happened even before 2016, because you start with phase 1, phase 2, then you go to phase 3. And you can see cares that I'm talking about only started in 2021. So we are always behind. We are always behind. And what should we do to cope with what is happening in the rest of the world? It is up to us, because nobody is going to be thinking and working for us. So what are we looking at now after we have these results and we are waiting for results for week 96 is, before our governments can adopt any treatment regimens, they have to follow the WHO guidelines. So we are talking to the WHO. They are having their meeting, I think, in February next year. And this is what they previously had in their guidelines regarding this long-acting ART. And I think now we are starting to give them evidence to, that they can use to support their decisions. So I think this is the last slide. And the issues is to engage low and middle income countries early, because we have the largest population of people living with HIV, and therefore we have the largest beneficiary population. And we know that differences in populations are there between high income and low income. But so we need to provide the evidence in our populations for adoption of these innovations. And you are all part of this journey. So if you feel energized, go and do something. Thank you.
Thank you very much, Dr. Sise. Thank you very much. Dr. Sise is our chief investigator on the CARES trials you've had. We thank also the COA sponsor team, and yours truly is the investigator on this study as well. So that's where we are at. Now, this is how we are going to move. Since you've seen the program, we're going to first finish up with the cases. After the cases, we'll then have Alison and Dr. Diana, then wrap it up with Dr. Dix on the HIV cure research and agenda. So from the cases, I think we're going to discuss the case that Dr. Odongo projected for us, and we'll have some questions. Thereafter, after the discussion, we shall have the case that will be from Dr. Francis Sally. One of the questions from the virtual audience comes in from Amoru Christopher, and is wondering what could be the likely cause to resistance to the other drugs that the patient was not exposed to. So I think most of the drugs have been presented to us, and then Christopher is asking what could have been the cause to resistance of the other drugs that the patient was not exposed to. Then the next question was, why was a client taken back to DTG, yet in 2023, the results showed that the child was resistant to it. We shall have just a few selected questions. I think we have another question that seemed to suggest that do we have any care homes that we can like OVC that we can help this child to get support socially. So we can have those, and the ones that Dr. Jen you have, maybe you can share with the audience so that we can have the discussion for the case.
Okay, hello. Are there any people in the room who had a comment or question for the case, the presented case?
Thank you so much. Sambata Bernard from Scaling Up Nutrition and Food Security. My first question goes to Mr. Odong. Along the way, he mentioned on how this client, the one was sharing, the client that was worked on regarding malnutrition, but in the recommendation, you didn't have a recommendation regarding how to address it along the way. Then I appreciate the ED for the great research done, and a statement that I've taken away is having a scalable adherence interventions using low-cost friendly measures. That's where I felt it, if we integrate nutritional and food security programming that are best practices and approaches that are scalable to adherence interventions using low-cost measures. That's a statement has caught me so highly, and it's a takeaway for me. Thank you.
Bernard is a nutrition advocate. Anyone else with a question? Or okay.
Yes, thank you so much. Dr. Patrick, once again from JCRC. Thank you so much, our ED, for the great work so far done. So my question or my fear with the injectable ART, one, doesn't the rollout of injectable PrEP threaten future resistance for these big guns we have of injectable ART? Because we understand the misuse that goes around and the inconsistency with PrEP. Then second, from the baseline characteristics of the CARES study, we noted that majority of the participants were found to have prior exposure to NNRTIs, to which rilpivirine belongs, as seen with the studies on the archived mutations, something like that. So how certain are we that this suppression was not really a monotherapy due to cabotegravir alone? Just like we've seen similar cases on TLD, where somebody is suppressing well, but when you do an assessment, it's actually only DTG that is working. Thank you.
Thank you for summarizing. Okay, one more, then we'll summarize.
Yeah, thank you. My question goes to the first presenter, that was Dr. Odongo, who presented about the resistance. Now, from the presentation, we got facts that this participant was given the right drugs, And there was also a fact that the viral kept increasing. And we were also told that this participant was living under poor conditions with high malnutrition. So it is difficult for us to conclude that the drug was really resistant to the treatment if we didn't do anything to improve the other conditions that can compromise to the effectiveness of the treatment, like malnutrition. And it is also difficult for us to prove that this participant was actually taking the drugs. It is possible that under such conditions, he wasn't even taking the drugs. So was there anything done to prove this before we can conclude that the drug was resistant? Thank you.
Okay. The ED, you want to ask? Okay.
Mzee Jime or James Opeda. If I, just like with pill burden, but there's also injectable fatigue, can I be off a month and then resume my injectables while I'm on my pills?
Being bribed here. One more.
Thank you so much, Dr. Jen. My question will go to the first presenter for the case. Dr. Naiga Fairuz from Baylor, Uganda. I am the current national chair for the HIV Drug Resistance Committee. So my question goes to Dr. Odongo. I needed to know whether this patient was assessed for depression, because this is a 19-year-old male, and we see he has not suppressed since 2018. So we need to know if there are other barriers to adherence that are causing him resistance to the drugs. And then this is a young man who's staying with a mother, and we are seeing resistance, multi-class drug resistance. We need to know if the mother is suppressing on her treatment and what regimen she's taking, because there was a gap in that history. And then I think finally I'll ask about the anti-TBs and modifying his regimen because of drug-to-drug interactions. Jen is nodding. Thank you.
Hello, I think we'll ask Dr. Odongo to respond to what has been asked.
Yeah, and before Dr. Odongo comes in, I think we're going to first finish all the questions on the cases, okay. And then Dr. Sise will be answering some of the other questions that are directed to her talk. So I think maybe we can archive the questions for injectable ART when the time comes. We're going to first exhaust the cases.
Okay, yeah. Only the case, okay. Dr. Odongo, are you there?
Hello, I'm around.
Okay, please answer some of the questions that have been asked. Did you hear them?
Yeah, I captured some of the questions here. The first was about the issue of malnutrition, whether it was addressed along the way. So malnutrition was diagnosed 2023, the severe form, and the client was initiated on ready-to-use therapeutic feeds. Unfortunately, the supplies were not consistent. And currently, the client is still in moderate form of the malnutrition, hasn't gotten cured from the malnutrition. He's still on RUTF, although it is and there was also a question about whether there was really drug resistance concerning the case, or was it underdose, or was it drug resistance? So what I can say, the adherence has not been so good from the case presentation, and concerning the resistance, I believe the underdose due to the poor adherence is the one which must have driven the drug resistance. And about whether there was resistance, I strongly believe the resistance is there. And I believe the results from the drug resistance dashboard, probably it is a correct result. I believe the resistance is really there because this patient has not been given the chance to have good adherence due to a number of reasons presented earlier. And unfortunately, the patient doesn't have any documentation showing an assessment for depression. I believe probably it wasn't done. That is a response to one of the questions about assessment for probably mental health issues. And the mother is receiving care from one of the health centers, three is actually Boo, but unfortunately we don't know whether she is also suppressing, and we are not sure of what regimen she's on. Probably those are the gaps we have as a facility. We needed to know all those details. And also the issue of anti-tuberculous drugs in relation to the ART medications. I really don't know how I can answer that. I believe there must be a mistake somewhere in combination of the anti-TBs and the current that line is on. And there was another question concerning the DTG, why the patient was maintained on DTG, which was part of second line for the client. And yes, the result of 2023 had already shown high level of resistance to DTG. Of course, the patient was susceptible to TDF and lamivudine, but the DTG had already shown a lot of resistance, and why the client was still maintained on the DTG. I really don't know the reason behind that, but the third line was introduced following regional team discussion. Probably it is also a mistake from the facility, but that is what I found in the file, because if you look at DTG from 2023 already having high level of resistance, and yet it was carried forward. The reason I really don't know. Thank you so much.
Okay, thank you, Dr.
And I forgot one more question about OVC support, whether we have OVC support services where we can refer clients to. We do have in the previous year, the client was referred to Youth Alive Uganda and was offered such services, but that was a long time ago in 2021. Unfortunately, it has not been referred ever since. Thank you.
Okay, thank you, Dr. Dongo. Probably I'll also speak to what some of the online team had put forward, and then give Dr. Sally to summarize for us. So Cyril says the patient was subjected to monotherapy at the time of optimization. A common mistake where the capacity of health workers needs to be strengthened. And maybe to add to that, yes, there was viral suppression, non-suppression all through from 2026, but we saw that lopinavir was substituted to DTG at some point with non-suppression, then ABC to TDF. So a call on all of us to always follow the guidance. Because for optimization, the guidance from Ministry of Health is always that the patient should be virally suppressed. If we don't do that, then we are also contributing to resistance. Yes. The non-suppression, I think, has been talked about, and the causes. Then Shafiq says the patient may need tropism testing, so that we determine whether they can take Maraviroc or not. And then, of course, treatment literacy and improving adherence is key before the next regimen. Then we realized that this patient has been on darunavir only since January this year, but already they have high level resistance to it. Could they probably have had archived PI mutations to the LPVR that are now manifesting and probably have caused havoc to the darunavir even before it was used? That was probably the cause. I think that was it. I'll just give Dr. Sally to talk about tropism testing. Yeah, I think that's it.
Yeah, thank you. I think the case has been well discussed. The tropism testing refers to checking for drug resistance to Maraviroc, drugs in that class of medicines. Unfortunately or fortunately, the drug Maraviroc, the way it came in, it was put as a reserve drug. So quite often, by the time we try and see whether it can work, the patients have had, the virus has switched from being a CCR5 to CCRX4. So I think that may be the challenge. But a patient like this one with the, heavy drug resistance, we have to be very careful, I think, to do the testing when the patient is actually taking medicines, and then we see what two molecules can work for him, and on which we can add some other optimized background therapy. This is a patient, I think, who could benefit maybe from a clinical trial. Yeah.
Okay.
Yes, so Sisi has asked me to talk about lenacapavir. So we've had, at our clinic, we have currently about 4 patients. I think we have an application pending for a 5th one that we have had to, in addition, use lenacapavir, which is now like a long-acting every 6 months, once every 6 months. But on top of that, we still struggle to get other additional medicines. So this patient, perhaps there's a chance, but we really want to make sure that we correct. We don't repeat the same mistakes that were done when they were being switched from the previous regimens.
So we can probably send you this summary for that potential option. So the last thing I wanted to emphasize were the drug-to-drug interactions. PI and the rifampicin. Please go back and teach, and teach. Don't forget, because that also potentially contributed to the resistance. Remember, there was the PI in lopinavir 2018 with the anti-TBs. Probably nothing was done at that time as well, and this is where we are. I wonder if we have rifampicin now in the national. Those from upcountry, do you have rifampicin? Anyone?
Online, we don't see anyone
those are the
who is saying that
challenges
they have
that
rifampicin.
we have, but please look out for the drug-to-drug interactions, especially the PIs and rifampicin. Thank you. Back
Thank
to
you
Dr.
very
Tamale.
much, Dr. Jen. Thank you so much for coordinating this case. I think we shall have another case from Dr. Sali. As Dr. Sali is taking his podium, I can just introduce him briefly. He's a deputy ED for JCRC, and he leads efforts to continuously strengthen research and clinical services. He's a physician in practice and also teaches HIV medicine, internal medicine, hematology at JCRC and Makerere University School of Health Sciences. He's also involved in operational, clinical, and epidemiological trials of HIV treatment. He's an investigator on various studies, including SCTG network studies, HIV reservoir studies, pediatric dosing finding studies in rilpivirine, studies investigating the effect of ART in lymphatic tissue among PLHIV in Uganda. He investigates on protocols in development of cell and gene therapy trials, both in HIV and sickle cell disease. He's a member of the Global Gene Therapy Initiative, GGTI, which is an alliance of various experts working towards the development of and enabling access to cell and gene therapy products in low and middle income countries, including Uganda. So, Dr. Sali, you can tell us about the case and we discuss it.
Thank you very much, William. I think since we are talking about cases, I just wanted to remind ourselves about where we are in treatment. There's just a few preamble slides. Currently, we have close to a little over 1.4 million individuals on treatment. And the majority, 96% are on first line, and 0.1% are currently on third line. And we have a 3.5% who are on second line, meaning those are patients who have already had some form of drug resistance. And from our current data from the Ministry of Health, we have quite very good viral suppression, about 95%. You saw in the care studies, it was about that, again, 96%. That means we still have about 5% of the individuals that we're treating who are not virologically suppressed, and those are candidates for drug resistance. In the current categorization of patients, we have the category of the patients who are virologically suppressed, and currently the cutoff for viral suppression is 200 copies. Then we have individuals in the middle there whose viral loads are above 200, but below 1,000. Those are low-level viremia. And then we have the category of individuals whose viral load is 1,000 and above. Those were the non-suppressed. And those that the non-suppressed are the individuals if the viral load is 2 times non-suppressed. Those are the ones who go forward to get a drug resistance, whether they are children or adults. So the 200 for suppression, that was what was decided. But I know in the studies, like you saw in the study that was presented, it was at 50 copies. But at the national level, we are using 50 copies. We have various platforms that, especially the dry blood spots, which are not as accurate. Their level of accuracy, you can as low as 400 copies, but they may not tell you whether this is below 50 or below 200. So that's why we do have that group there. And I know you hear from Alison, we are now shifting more to plasma samples. So I'll just show you this slide, and I'm sure Alison will also show you this slide. I hope. So if you look on the left side of that slide, you see various bars of the drugs where in terms of resistance, and this one is actually where we are now. So the patients that fail treatment biologically on a DTG-based therapy currently, we have about 20% of those individuals failing with DTG drug resistance at intermediate to high level. So it is very different from what we had a few years ago. I think on the right-hand side of that slide, you can see that the DTG blue slide, the lower curve was previously low, but it is going up. So we need to be very careful how we switch our patients. You saw what happened in one of the patients that was presented from Kitgum. But it may not be very different from my cases I'm going to show you. So the cases I'm going to show you are patients who had cognitive decline while they were on antiretroviral treatment. And currently there are so many thoughts about what may cause cognitive decline in patients. Either they may have some inflammation, or the HIV itself, or the side effects of antiretroviral treatment, and some other comorbidities that patients may have. So at our clinic in Luvoa, the largest age category of patients we have are patients who are 50 years plus. And our average age is now about 46 point something among the patients who are getting care. And we find many of these patients may have comorbidities. Some of them have been on antiretroviral treatment for quite a long time. And some of the issues around them may be social, we may think they are age-related. In some of them, there could be, things like substances, or even the HIV itself. And as you've heard, we look at the viral load to say patients are well suppressed. Some of the theories about cognitive change in HIV have something to do with the guts leaking bacterial particles, and they thought to be going to the CNS. But I'd like to draw your attention to the fact that the ARVs we are using, not all of them have the same penetration of the CNS. For instance, a drug like atazanavir penetrates the CNS far less than the darunavir. And it might explain some of the changes that I will show you in this patient I'm going to show you. And this was a study looking at different drugs, how they penetrated the CNS, and you can see that some medicines have quite low penetration, others have quite high. And many of us, we don't have ability to check for cognitive changes in our clinic. By the time we pick it, it is really quite gross. So the first case I'm going to show you is a 71-year-old patient. She presented to us with cognitive decline and incoherence, and she had lost some memory. She, besides being on ART, she was on systemic treatment for hypertension, and also on a number of medicines for that. And her viral load was less than 50 copies. And she had in the past, been on AZT and developed anemia. That was her first regimen, 2004. And then she moved to abacavir. And then, when we got TDF, at some point she got osteopenia, so she was moved back to abacavir 3-TC DTG, and then she developed diabetes on DTG. So it was very difficult to treat this patient because of the side effects. And eventually she settled on ratuximab and atazanavir, and her viral load was suppressed. However, when we did her CT scan, at the time that she presented with these cognitive changes, this is what we saw in the CT. She had multiple gliotic areas, especially in her white matter. And the CSF, when we examined it, was essentially normal. The only abnormal finding was a high viral load. Very high, much higher than what we had seen in her blood. And although this patient, we didn't do the drug resistance at that time, her ART was switched, and the patient, everything resolved. But the next case I'm showing you, this one we managed to get a drug resistance on the CSF. This is a 55-year-old man, again on treatment for systemic hypertension, diabetes, and she was an executive. She got memory issues. She started getting hallucinations at home, and so his partner actually brought him to the clinic. Although the hypertension and HIV were all suppressed, viral load was undetectable, and the patient was on ABC3TC and DTG initially, but then was switched to atazanavir and ritonavir plus RAR, and viral load, as you can see, was below 50 copies. And when he had the MRI imaging, you can see again this patient, especially in the posterior areas of the brain, he again had some gliotic areas, and the CSF part was normal protein, normal cells. The only abnormal finding was a high viral load in the CSF of 27,000 copies. And yet the blood CSF, the blood viral load was suppressed. The last case, I'm going to show you this last patient we saw. We haven't done a repeat viral load on this one, but this is a 51-year-old woman who has again been on therapy for quite a long time, and she started getting delirium and poor memory, and her family brought her to the clinic. And at that time, she came with a viral load of 1,125. When we repeated it, it was 2,300. So we did again a CSF analysis on this patient. Everything was okay. Cells, protein, you know, all the microbiology, everything was fine. But she had a high viral load, much higher than what she had in the blood. And this was her CT, her MRI. Again, you can see there's a lot of gliotic areas in the white matter, and quite enlargement of the cerebral ventricles. So to summarize these three cases, case number 1 had viral load suppressed below 50 copies, CSF 415,000. Case number 2, again viral load suppressed, CSF 27,000. And case number 2, we were able to get some mutations. This patient had in some integrase mutations. I think that N155H significantly dents the raltography that the patient was taking. Then case number 3, you can see she also had, in the plasma, she had mutations to PIs, to NNRTIs, NRTIs, and none in the integrase. And in the CSF, she had a similar pattern, but she had more mutations to the PIs. These cases, in the last case, we think that perhaps the resistance started in the CNS. In all these patients, we think that's where it started because of the differential access of the medicines to that compartment. And subsequently, it does spread to the periphery. So not all our patients develop resistance from non-adherence. Some of the patients, a few of them, as you can see in these patients, it may be that the drug, the virus gets sequestered in some compartments which are not easily accessible to by the medicines. And as patients stay on the therapy for a longer time, all these patients you've seen are well above 50 years. So in conclusion, I guess from the first slide that I showed you about drug resistance, I know all our first line, second line, third line, we have DTG, but we have to be very careful how we switch patients, how we transition them, because even our very good drug, we are beginning to risk losing it. The good thing is that still, you know, we have close to 80% of individuals that still may be susceptible, but we need to check which ones. So we still need to do drug resistance among our patients. And also we still need to look for new molecules because if DTG is threatened, and we need in the next couple of years to have something that will work very well. And then the HIV-associated neurocognitive disorder, or VRT, if you do see a patient who has cognitive decline and yet they are biologically suppressed, please investigate them. In some of them, it may be that there may be some virus sequestration in the CSF, and that's something that you can potentially reverse when you give them the right therapy. Thank you very much.
Thank you very much, Dr. Sally. Dr. Jen will coordinate the questions in-house for your case, but as she does so, maybe the question would be, was there any resistance testing done on a CSF after, you know, the cognition challenges were reversed? Did we do any CSF follow on to see whether there was virologic suppression?
Okay, I think we'll take maybe a few more.
Yeah, thank you. My question goes to Dr. Sari, and specifically about the cognitive disorder he has just mentioned. So my question is, do you usually take the baseline cognitive status of the patient when you are starting them, so that at a later stage, you are able to tell whether there is a decline or not. Secondly, I would like to know more about the tool which you use to measure this cognitive status. And lastly, the effect of the age, because you've mentioned that most of your patients are aged. So the effect of the age, because as people age, several disorders set in. Thank you.
Thank you. Any more? Okay. Maybe as I go to the person, I was just thinking maybe this has his privilege to be able to do resistance testing on the CSF. Are we able to do it even from the peripheral sites? And what would be the procedure?
Thank you very much, Dr. Sari. Christas Atkwase from JCRC. Partly, my questions, he actually previous speaker mentioned the two of them. So me, I would go straight to the third question which I had. So in terms of systems, for example, of what we've already done in guidance, what can we improve? Or what is the provision in regard to care for such patients who are coming up with cognitive dysfunction? So what should we do? In our system, can we have maybe, can we have a policy change, or do we have a provision in guidelines? Thank you very much.
I'll first let you answer those, Dr. Sali.
Yes, thank you very much. These are very, very good questions. We have not had a chance to reassess the CSF, but in these patients, what we did is the medicines we switched them to, we based them on the drug resistance pattern that they had in the CSF. So far, they have improved very well. The first two, we have not been able to get back into their CSF. The second one, we are going to check, I think she should be due for her viral load, plasma viral load in the next month or so. We haven't yet considered to get her CSF, but maybe it may be something that we might consider. We also got worried that maybe there are many patients that we miss, because these patients, these three, they were brought to us by the relatives. They said, you know, the patient, we don't understand the patient these days. Everything is bizarre, sees things that are not there. One of them was just delirious. So these were extreme cases of cognitive impairment. And I'm sure the issues are there very many that we are missing. Most likely, yes, because we are just seeing the tip of the iceberg. That's what I think. And we do not yet have very good tools in our national guidelines to be able at least to screen for cognition. We have one for depression, but I think we don't have one very good one for cognition. And also, I think our previous management has been we've been looking at relatively young population, but now we need to see how we can transition to be able to address the older population which has comorbidities. So that's for the national team, I think, to think through. The age-related, I think these cases, you saw they had comorbidities, and we should not just sweep things under the carpet and say, this is old age. I think we should investigate the patients. So the other one was the cold chain. Yeah, so I think this DR can be done if the sample can be maintained very well. And I think Alison is going to show us, because I think there's been some investment in moving plasma samples, and I think the same mechanism that can move plasma samples should be able to move even a CSF sample. I think that's what I can say. Thank you very much.
Okay, just one more from the online team. Henry, so what are the best ART regimens in the current guidelines that can be used in CSF sequestration?
I think our current guideline, TLD, is quite good. DTG has very good CNS penetration, even tenofovir. But you can see those patients, they had issues that for some reason we could not, they could not tolerate DTG. Okay. And also they had issues with tenofovir.
Okay.
Yeah.
Okay. One last one.
Good afternoon, everyone. All protocol observed. Thank you so much, Doctor. So I'm wondering on the part of, my name is Doreen Alio Rutakiamira, a resident at Makerere University College of Health Sciences. So I'm wondering on the part where we are talking about the cognitive decline and the neurocognitive disorders associated with HIV, other than just the assessment tools, have we considered maybe having a specialist on that particular part? I mean, a psychiatrist to actually really review these patients and assess them and come up with a proper diagnosis so that we don't miss out on anything. As just calling it on the assessment tools that we are using when a person is not an expert on that, and then they conclude that this patient actually indeed has cognitive decline or a neurocognitive disorder when actually it's not. And so I am wondering what interventions would you recommend for managing these symptoms in the context of their age and clinical presentation, which I still think that having an expert on that part, and this, in this case, a psychiatrist, would actually really be helpful. Thank you.
Thank you very much. Actually, these patients had been managed on, they came to the clinic on psychiatric medicines, but they were deteriorating even on psychiatric care. And that's what prompted them to get to the clinic for more checks. So I think all of us need to be informed, even the psychiatrists, but also we have very few, actually there may be, I don't know how many of our clinics have a psychiatrist or even a psychologist. So that's a very big gap that we have. So we will need to get some simple tools that can screen out patients that we can then maybe we can look for care for the neuro experts. But it's something that we must think about.
Thank you very much, Dr. Sally. And members, we don't forget referrals where you feel it's a little bit tough on your end. Okay, so the next presenter will be Alston Aitewala, according to the program. So Mr. Alston is a Ugandan scientist with distinguished career. As I read maybe the bio, you could take the podium so that we don't waste out of time. He has a distinguished career in molecular biology and biotechnology. His work focuses on optimizing patient care through evidence-based approaches, particularly in the fight against HIV. He holds a master's degree in molecular biology and biotechnology from Makerere University, and he has also earned a bachelor's degree of biomedical laboratory and technology from the same university. His experience is in HIV, his expertise is in HIV drug resistance management. He has done some work with HIV genotyping laboratory at JCRC and is currently managing the genomic laboratory at the Central Public Health Laboratories, CPHL in Uganda. Mr. Alston, we are eager to hear your word. Thank you.
Thank you very much. This is Alison, and my job is already simplified by Dr. Sally, and I'm just going to give a few. My presentation is going to be in two sessions. One, I'm going to present a bit of the programmatic aspect, and then we enter into the highlights on the HIV drug resistance. Which I'm comfortable, I have my seniors in the room who will support with those questions. Yes, so now As an entry point to the HIV-DR care cascade, we have, and I think from this point, let me answer the question that was highlighted, whether we can do HIV drug resistance on CSF from peripheral sites. You know, the entry point is viral load, and before we establish that capacity, thanks, JCRC is still leading us in evaluating the possibility of doing that in a public setting. And thereafter, we shall include DR. So as Dr. Sally mentioned, I think we are making progress in terms of viral load suppression. The trends are looking a little bit better, and I think we are achieving the unit target, at least the last 95. And when you look at this, you can tell that achievement has been with the scale-up of DTG-based regimen, mainly as you look through the years. And we can see that consistently in 2024. However, you can look at the new treatment guidelines now emphasize the importance of low-level viremia, that is below 1,000. As much as we are achieving at the 1,000 copies per mil, I think there is a risk, and we need to monitor more and make sure that blue line also for the low-level viremia drops to 9, at least 5%, as you can see through the next slide. Oh, the one with the control. Okay. So that is our entry into DR. Now, when we go to DR specifically for 2024, we have seen and here the trends of the eligible patients. I started with 2021, but there has been work that was ongoing with all the labs, JCRC, VRI, since 2017. But by then we had not put an electronic system to monitor these. So we analyzed directly from the database. But we can see an increment in the demand for genotyping services, and that's because of the importance and the significance it has shown in patient care optimization. But specifically for 2024, like for example, from Jan to now, the eligible patients should be like 11,000, but we are having missed opportunities. Only 57% have accessed the DR. There are a lot of challenges that we still have, and we are addressing mainly the issue of the sample type, first of all. We still have facilities that utilize DBS, and that has been challenging for HIV genotyping. But still, along the cascade, you see we are missing opportunities. Even for those that we send with the plasma sample, you find that there are those that we don't refer, mainly because we have utilized the remnant sample at viral load. And going down, you can see even those that we genotype, some fail. All challenges of cold chain, which we are trying to see that we address going forward. But at least we have a significant number that still accesses a DR, and they utilize their results for patient care optimization. In regards to the testing labs that have been testing since this is a slide from 2021, JCRC, VRI, and CPHL, we're seeing an improvement in these labs' performance, and we can now comfortably say that you can access a result, an overall result within less than a month for now, which is very significant compared to where we started from. We've seen even results being received at facility within 14 days. Now, I'm moving in terms of the care cascade, the viral load, the testing. Now we have the case discussions. At first, we started with national committees that used to discuss all the cases across the country. But with the support from the experts in the House, we have been able to decentralize this, and we have regional committees which will further decentralize this case discussion to the facilities, to the districts and facilities. Now, we envisage in the next 3-5 years, it will be a disservice to have an ART clinician who cannot interpret DR results. The way you interpret viral load, you should be able to interpret the cases. So, and there is work ongoing and mentorship at regional level to support that. But you can see that with this decentralization, we have drastically improved the case discussions. You have now over 90% case discussions in some regions, and the turnaround time is going down from 5 months to now we are talking of days, including now. After that, there is the bit of initiating after the cases. You send a feedback to the facility, which is done electronically through the system. We have improved that also further, at least now to 23 days. Facilities can respond and initiate ART, appropriate decision making. So having said a bit of the program, what are we seeing? And this slide, Dr. Sari has highlighted on it or hinted on it. For the acquired drug resistance, just to mention, this is acquired drug resistance. Yeah? The picture is different from the general. There was a survey that was done, I think it's around 5%. Acquired drug resistance at virological failure. We're seeing DTG resistance at least around 20 going up. But for me, I'm looking at the positive side. We're looking at 78% of the patients who can still utilize DTG, okay? And this underscores the need for HIV genotyping. If there is a service, please utilize it. Let your patient get access, such that we save the patients from being switched to more expensive drugs, but also leaving a 1 pill to 2 pills a day is also not a burden you want to send to your patients. So our data tells us that it's very important that we do a DR, because there is 78% that can still utilize. But resonating from Dr. Chitio's presentation about cabotegravir, it's now more than ever very important to monitor for drug resistance, because these are our future options. But you can see the level of cross-resistance within this class. You cripple DTG, you have crippled your future injectable. So it's very important that we monitor these. Now, when you look at the trends of the anchor drug, we have DTG and the backbones, ABC, IZT, and TDF. Interestingly, and let me ask a question in my own presentation. Why are we seeing the backbones declining, DTGs skyrocketing? Yeah? We don't know this phenomenon. I think maybe you would explain, maybe there's some that needs to be done. What's happening here? When you look at drug resistance in age and drugs, on a scale for the years that we have been monitoring, 2021 and 2024, I think the biggest highlight here is that we need to pay more attention to the adolescents, and I think this is, you're also seeing how challenging they are in the clinics. Overall, they exhibit high level prevalence of resistance compared to the other age groups, and specifically abacavir in the children 0 to 9, and it's almost their only option until we get tough, tenofovir, that is much friendly to them in terms of safety. So it's very important to keep tabs on the adherence and all that. Yeah. So when you look at it from a geographical scale, the distribution of resistance for the different drugs, at least for 2024, I think we still see a noticeable difference across, which calls for targeted interventions. We know that there are good, there are regions that are really doing well in terms of programming, and I think the support needs to be enhanced in some. A unique pattern, although, is that we expected, since the majority of our patients are on TLD, that we should have a similar pattern of TDF and DTG. But now this makes sense from the previous slide, why we have declining resistance of TDF, but increasing DTG. What explains these phenomena? Yeah, but you can see that ABC across the country, we even have some that are above 50% at failure. It is not an option anymore. So going a little bit into the details of mainly the instile resistance with the subtypes, yeah, just to mention, still we have HIV subtype A as the majority, followed by D, but we are increasingly seeing B and C and other recombinants popping up within the population. In terms of the prevalent mutations, we have E138A and K, and then the G118R, which is most prevalent for all the integrase inhibitor drugs. So, but then what is worrying is the G118R, because that alone can cripple DTG. Now, if this one, we don't manage our patients well, and we have the case we had with NNRTIs for transmission of this resistance, that mutation alone, if it reaches 11% within a population, we are losing DTG at a population level scale. Yeah. We're seeing some interesting patterns with the differential patterns with the subtypes in regards to the development of mutations. But I think we need more research, and as you hear, maybe you can leave with a question to answer. Yeah, that's what I had to say. Thank you very much. I acknowledge GOU, the AIDS Control Program, the National Committee, the chair is here, the regional committees that are doing a great job, and our implementing partners, but mainly our genotyping labs. Thank you very much.
Thank you very much, Aliston. So we'll have the next presenter, Dr. Diana, who is going to talk to us about selected research findings at JCRC. Dr. Diana, as you take the podium, Dr. Diana is head of pediatrics at JCRC, and she's highly skilled and compassionate pediatrician dedicated to the health and well-being of children. She's actively involved in the outreach program spreading awareness and child health and safety. Her dedication to the well-being of young patients and their families has made her a trusted figure and a commander in the field of pediatrics. Commander, take it up. Thank you.
Thank you, Dr. T. Dr. Tamale, good afternoon. Thank you for your kind introduction, and thank you all for being here. My task is actually quite simple. When they say selected findings, and Dr. Sis has told us about CARES, and also talked about Impala, and we have Professor Msime study who talked about CHAPAS and the other DTG-based studies, it becomes a lot easier. But I'm happy to tell you a very brief story about the birth of JCRC and how we have selected our studies and how we get to be part of this meeting today, since all the years back, that we can, with some degree of relative confidence, say that we have participated not only as small-time partners, but as big implementers in clinical research. As you've all heard, and those who have not heard, JCRC has been in being for quite some years. We celebrated our 30 years not long ago. And our birth is based on the need to manage HIV in Uganda. And I just put 3 bullets over there, that when we were in total confusion in 1982, when the first person was identified to have SIRIM, in English it is SLIM, which basically defined what the person looked like, and that was the abnormally slender size. Total confusion because they were very sick, they were in need, and there was no answer to what it is that was biting, that was eating away their bodies. And in 1990, JCRC was born out of an understanding between the government, College of Health Sciences today, and the JCRC, a few people then. What they thought was a small idea to treat is now a very big idea that we all sit and celebrate. So a big part to every one of us here for making the JCRC what it is today. And in 1992, we launched into research. The first of its kind then only used one drug. The bioethicists, the regulatories may make a lot of noise that was unethical. But at that time, what else was there? We had no alternative except that one drug pill. But also it led us into discovering the lowest possible means available for LMICs like Uganda and so many other countries around us. And slowly by 2007, we had gotten into pediatric research. I cannot not talk about pediatric research because I'm born in pediatrics, really, and I plan to stay there anyway. And there's so many researchers from the JCRC have gotten us out of the traditional kadomola. Any of you here saw a kadomola? Any drug that was in a jerrycan, a bottle? And now we celebrate of one pill, the single pill today, for so many people. And that one pill has come from many trials. We have the DAT trial among the adults that many of you heard of, but some did actually participate in. We had the START study that helped to also lead to the test and treat policy that is now part of our day-to-day, everyday practice. It just did not fall. It actually came through trial. But more so, I would like to talk about research that has transformed policy indeed. You have heard of the Odyssey trial, the once daily dosing with DTG. In this particular cohort, sorry, I'm going to skip since I talked of Odyssey first. In this particular cohort, those that can approach Google, you will find many write-ups on Odyssey trial. We were looking at children, both naive and experienced, and how DTG would work best for them. So we had several weight bands, as young as 3 months, as small as 3 kilograms, up to 18 years. 18 years would go up to whatever age they had. And this is one trial that we are happy to celebrate with all participants, all partners, because it has led to our current practice of pediatric DTG dosing in the young ones. Prior to that, we had lopinavir that came as a syrup, and that was very difficult to manage because it required refrigeration. And with many LMICs, power is not a guarantee. Having a refrigerator is more of a luxury than a basic. So having a disposable tablet that can be stored anywhere in your house, in our houses, in their houses, has brought a lot more comfort. But further to that, it was found that actually DTG is quite tolerable. It has very few side effects. Adults complained that it was associated with weight gain, but for our children, we have actually had stable weight gain that is comparable, that was in the trial comparable to those that were on standard of care. So we are good to go with pediatric DTG. Though with Dr. Sally and Alison's presentations, there are a lot more question marks that keep coming. How far can we keep them virally stable, long-term, on DTG with all the worries of mutations, resistance, and all? Yesterday, Professor Msime specifically talked about CHAPAS 4. CHAPAS 4 was a pharmacokinetic study where we had 8 trial arms. One were looking at the backbones, and the other were looking at DTG and other molecules. And we're specifically looking at acceptability, efficacy for second-line management. Because many children actually will do run out of options. Running out of options for pediatric is multifactorial. Many children that are HIV positive are orphans, so they've had to be transitioned through so many homes, many carers, weak and strong support systems. They have to go to school, and you can never be sure, are they actually taking their drugs? So failure has come as a result of that. Whereas a carer will tell you, I do give the child drugs. The child may tell you something else, that they're actually giving themselves drugs, or it is the helper or grandmother. Grandmother is partially blind. She cannot actually read the clock. Sometimes there is no clock. Others are using news broadcast as time. So CHAPAS 4 specifically was addressing treatment options for second-line treatment in children. And as Dr. Victor shared yesterday, they did have some interesting findings. The DTG-based regimens were safe and cost-effective. However, there were about 17, he talked of 17 in the CHAPAS 4 cohort that actually had mutations to DTG. The other great finding was that fixed-dose combinations of DTG, darunavir, deritonavir, atazanavir, ritonavir, NRTIs were all good enough. They were actually not inferior to the current standard of care. And if we were to adopt them, and I hope we do, they will provide actually better access for many of our children. But then again, how about the CNS management that Dr. Sally has talked about? We actually cannot take these things for granted. And the darunavir and atazanavir were safe in children. In this particular study, we had dose de-escalations for the different weight bands, and that's how we did come to those conclusions. They're all in print today, so please do read up, and you'll actually confirm that these are true and possible for us all to actually get to know more, like Professor Msime shared yesterday. The other third trial I'm happy to tell you about is the A534 protocol that was conducted under the ACTG trial. As you heard Dr. Tamale, he introduced our ED as the vice chair of the ACTG consortium. In this particular trial, we were looking at rifampicin-containing regimens versus the standard of care. And one very interesting finding in this study is that the efficacy of the 4-month therapeutic regimen with rifampicin is not inferior. It's actually very efficacious compared to standard of care. Our personnel here from government program are very aware that actually this is going to be the next guideline. It's been approved by WHO. So please, we celebrate with all the physicians that have been managing TB and worried about the long-term regimens. We do have a shorter regimen coming up. We're hopeful that this will be launched in Uganda very soon, at probably the next World TB Day. And just to hint on the fact that long-acting...
So along the way, as we also did the ARVs, also there was an idea of
in the same breath that we boast of the 1 pill a day, we actually look forward to the long-acting ART that Dr. Sisi talked about with the CARES trial and Impala that was done in Fort Portal that is now trending on their CVs. In the pediatrics, we also do have LATA trial. We do have 2 arms. One is on the long-acting therapy, the other is the standard of care. I have no results to share on any of these 3 trials, as a matter of fact, because CARES has already been presented at length. LATA results are pending, and there's nothing to disclose, but we like what we are seeing. The injections that are given once every 2 months have made our adolescents more comfortable, they are happier, and they are quite free to live their lives like any other of their peers. What do we celebrate about research at JCRC? We believe what the work we do has guided policy. Dr. Elena Magogo, Dr. Jenna Kawesi, Dr. Francis Ali will attest to that, that findings from the Odyssey trial have actually strengthened what we do nationally and at the international platforms. The A5349 TB treatment protocol is going to transform our TB care practices. From research, we have also adopted evidence-based practices. You and I know as clinicians, we don't have to wait for a launch of a guideline nationally. We can also learn from what we've learned from research. Things such as CD4 testing algorithms, viral load algorithms. Today we have been informed that actually the smaller tissues like CNS, I believe lymph nodes, spleen, will actually need more of our wakefulness while caring for our patients, even before policies are passed out, before guidance is given by national programs. We now actually have to pay attention. Findings from research on an every day-to-day basis do actually guide us to offer better care. I don't think any of us can sit back after learning something good, and we do celebrate it too. And research has enabled us to make collaborations, networking, as individuals, as institutes. Some people are doing PhDs based on the research work that we do. People have gotten married, gotten investment programs out of research because of the collaborations we make. True. But that doesn't go without challenges. We still have profound challenges, and we're not going to sleep about it. We will not hide our heads in the sand. There's a shift today in the global agenda. All meetings happening in Dubai, Abu Dhabi, Australia on climate change. So as clinicians, where do we stand? How can we leverage from the climate change agenda that is going on? We have increasing pressure to find cure and stop relaxing, thinking that since we have one pill, long-acting, how about cure? Pill fatigue is real. Injection fatigue will come up. I think within 4 or 5 years, our patients are going to complain. They can't stay on injections every 2 months coming in for a jab. We have a declining incidence of HIV. But yet, Alison and Dr. Sally are telling us the mutations are at 20%. Is it actually declining? UNAIDS tells us 95, 95, 95 today. There is a bigger agenda to have elimination by 2030. Those are just 6 years from today. Have we solved the problems? How about the new programs that are coming? How do we integrate them in what we are doing today? So as JCRC, we are not sleeping. We will continue to do research and continue to do research. And some of the areas we are looking at are the non-communicable diseases associated with HIV, HIV treatment, long-term care. And particularly, we're now looking at cardiovascular studies to understand their effects on the person that we're treating, effects, medication, management with ART, because some is born from ART, some is born from actually HIV. We're also doing cell and gene therapy as an agenda. It is strong. Dr. Samale informed you, we just had the first symposium, and would like to understand, is this the cure? While we just want to understand it, you know, Africa has been left behind. The patients that actually given us testimonies for cure, none is in Africa. They're all out of Africa. But where are we? Dr. Sisse, Dr. Sali, they are all at the forefront of the GGTI, and I think they'll give us an answer together with our efforts on this. We're also looking at monoclonal studies and other cellular therapies. Can they help us to address the mutations? Can they help us to address the concern about CNS penetration of the ART? We continue to partner with the vaccine consortiums. We are looking big into sickle cell disease with small molecules and transplant therapy and trials. genetics and genomic studies. Yes, we are. I hear somebody humming. Yes, it will be at our next update meeting. We'll tell you how far we've gone with that agenda. Otherwise, I thank you all. I told you mine was a very simple one because we'd had the big presentations. I thank our partners, those that have come in today. I thank all our participants at the JCRC, management. Did someone take off my thank you slide? Our big sponsors and collaborations, Bill and Melinda Gates, EDCTP, Caring Cross, Penta, ACTG, NIH, to mention but a few. Thank you.
Thank you very much, Dr. Diana Rutebarika, our commander. I'm sure the Field Marshal, Dr. Sise, is very proud of you. So the next one is a good session, and it's going to open up your attention. That is the HIV cure research, and it's going to be presented to us by Professor Steve Dix. He also talked to us at the first Cell and Gene Therapy Symposium. I think those of you who attended, you remember. So as he gets on, as IT puts him on, a small bio about him. Stephen Dix is a professor of medicine in residency at University of California, San Francisco, and a faculty member in the Division of HIV, Infectious Diseases, and Global Medicine at Zuckerberg San Francisco General Hospital. Stephen has been engaged in HIV research in clinical care since 1993. He is a recognized expert in HIV-associated immune dysfunction and its impact on HIV persistence, that is a reservoir, and health during antiretroviral therapy. He has published a number of peer-reviewed articles, editorials, and invited reviews on these and related topics. There are over 600. Stephen has been a recipient of the several NIH grants and is a contact principal investigator of the Delaney AIDS Research Enterprise DARE, an NIH-funded international collaboratory aimed at developing therapeutic interventions to cure HIV. He is also a principal investigator on the AMFA Institute for HIV Cure Research. Stephen is a co-chair of the Towards an HIV Cure International Working Group and a former co-chair of NIH Office of AIDS Research Toward a Cure Planning Group. He was elected to the American Society of Clinical Investigation and Association of American Physicians. He's also an editor-in-chief of the Current Opinion in HIV and AIDS and serves as on the Scientific Advisory Board for Science and Translational Medicine and the Advisory Board for E-Biomedicine. In early 2020, he leveraged his HIV research program to construct long-term impact of infection with novel corona cohort, which is now supporting dozens of studies addressing the impact of SARS-CoV-2 on health. He is a former member of the Office of AIDS Research Advisory Council and the Department of Health and Human Services panel on antiretroviral guidelines for adults and adolescents. In addition to his clinical and translational investigation, he maintains a primary care clinic for people living with HIV. Professor Steve, are you online?
Hi, everybody.
Yeah.
Sorry I can't be there in person. I was actually in Kampala about 10 days ago. I just couldn't make the trip again. Today I want to talk about HIV cure, talk a little bit about the background, progress being made, and where I think the field is going. Question number one, though, is why do we actually need a cure? As we all know, antiretroviral drugs work great for both treatment and prevention. In fact, these two high-profile studies recently released suggest, at least in an African population, treatment and prevention is nearly 100% effective at suppressing the virus or preventing infection. So why don't we just say, game over, we won, let's move on. I think the main reason that the field is really sort of pursuing a cure is not to address the individual needs, but more of the public health stuff. Here's the most recent update from UNAIDS about 90-90-90, or 95-95-95. Despite these wonderful tools and a massive global investment in public health and implementation, only about 70% of the population right now are on effective ART, and only about 50% of children. People, as we know, go on and off therapy. It's really hard for people to stay on treatment indefinitely. And despite effective ART, we still basically are experiencing excess amount of mortality. In fact, there's one person dying from HIV-related causes every minute, and transmission events continue to be at a high level and stable. So, to address this, right, we need a number of interventions. We need an effective vaccine, but I actually think a scalable, effective cure, one in which we can go out, identify those people who are being left behind, the 30% of people on the global level who are not on effective ART, make the HIV diagnosis, perhaps give them a shot in the arm, they're cured, we move on. And my presentation today here, I'm going to argue that that approach, that single shot approach to curing HIV, which we thought before was aspirational, science fiction, is increasingly becoming a potential and a possibility. So let me see if I can make that argument. All right, before going there, let's talk a little bit about the HIV reservoir, what the provirus looks like during long-term treatment. When people go on antiretroviral therapy and stay on it for decades, at the end of the day, there's about 1 in 1,000 circulating CD4 T cells that harbor a provirus that can replicate. So it's very rare, difficult to measure. A key part of all the studies regarding the HIV reservoir is the fact that the vast majority of stuff that exists during long-term treatment is defective. It cannot replicate. It can make proteins, and those proteins can cause chronic inflammation, which is probably not good. But even though these cells, even among the rare cells that are infected, the vast majority actually harbor a defective genome, making the measurement of the replication-competent virus very complicated. And now we have a new story, right? It's not only the fact that the number of cells that are infected are rare, and the number of cells with intact genomes is even rarer. Turns out that actually the location of where the virus is also important. When a cell becomes infected with HIV, it ends up randomly in our chromosomes, and the vast majority of our DNA are not genes. It's just sort of this, these gene deserts, which is basically nucleic acid that doesn't do much, we don't think. It may be structural, maybe regulatory and so forth, but it's not genes. And HIV that enters into these areas, heterochromatin, these so-called gene deserts, it can't replicate. It can't come out. It goes in, stays there, it doesn't come out. So the HIV that we worry about after a couple decades of therapy are, again, the intact genomes, which are rare, that are actually in genes, which is exceedingly rare. I say this because this is actually shaping the way we think about how we're going to measure the reservoir over time and how we're going to target it. Okay. A question that the field is dealing with is what happens to that replication-competent provirus population during long-term therapy. On the left is a study that we published suggesting that if you look carefully over time, the virus goes down slowly for several years and then sort of levels out. Some have argued it actually may continue to decrease at very low levels indefinitely. Bob Silicano and his team, on the other hand, are now arguing that the provirus population, the replication-competent virus population, does indeed go down for a while, but then after a couple decades begins to go up. Perhaps because the cells that actually harbor that intact replication-competent virus begins to expand clonally. The truth is probably a bit of both. This one study from the ACTG showed that in some people, the virus population appears to drop continuously. suggesting that they actually may be cured if we wait long enough, while others sort of go down and stabilize and others go back up. Anyway, this is an area of intense investigation as to what the natural history is of the reservoir over time. All right, so getting to the cure. Do we have reasons to be optimistic? Well, I believe pretty much everybody in the HIV business is aware of these cures that we're seeing. There have been now 5 examples of which people with HIV develop cancer, get a bone marrow transplant from people who lack CCR5. CCR5 is the way HIV enters CD4s. When you rebuild the immune system with basically T cells that lack CCR5, you can cure people. And there are 5 cures out there. And 2 additional ones that are sort of emerging, in which actually we're seeing a similar effect even in people who actually have a CCR5 intact population. Anyway, these cases are fascinating, they're inspiring, but to be honest, I'm not entirely sure they're actually providing us with true roadmaps as to where to go next, because these are complicated procedures. No one's ever going to have a bone marrow transplant just for an HIV cure. The mortality is too high and so forth. I actually think the inspiration is coming more from these cases of long-term control, okay? We know about elite controllers, about 1 in 100 people who become infected with HIV are able to maintain control of their virus naturally, without interventions, indefinitely. These are elite controllers. And in fact, there's a subset of elite controllers that we think have been cured. 2 women, including Lorene, who's shown here, from the San Francisco Bay Area, as far as we could tell, have been cured naturally. We don't know why. We have theories, but these cases are rare, but I think we're going to hear more about them in the future. And then we have the so-called post-treatment controllers, the Visconti effect. About 1 in 10 people who go on therapy early, stop drugs, don't rebound. Treatment is actually inducing long-term control. Mechanism unknown. And as I will now argue, we're actually now seeing evidence, particularly broadly neutralizing antibodies, that some of the interventions that we're doing is also causing long-term control. Essentially, in all these studies, what we've learned is that if you have a potent host immune response that involves CD8 T cells, but probably other parts, then in fact you can actually control the virus indefinitely. All right, so how are we going to achieve this therapeutically? So right now, the cure space is dominated by this sort of multiple shots on goal. We have a number of ways targeting HIV to reservoir to get rid of it or to reduce it. We have another whole set of approaches in which we're trying to manipulate the immune system so that the virus can be controlled. And then we have a growing area of cell and gene-based therapy that can do both. All right, so targeting the reservoir. So the earliest attempts at an HIV cure involved the so-called shock and kill approach. This is where we basically take people in long-term treatment and we try to shock that virus out of its hiding place and then hope that the cells will die. And to date, we've done, in people at least, we've shown that it's possible to turn on virus production. You make RNA, but we can't yet make viruses and we can't yet get the cells to die. So this approach so far hasn't really worked that well, despite a lot of effort. But we've learned a couple things. One thing we learned, getting back to the reservoir, is that the cells that harbor the virus, the CD4 T cells that harbor that intact genome in those genes, the virus that we worry about, those cells, after 10, 20 years, are quite resilient. It's sort of Darwinian, right? They basically have persisted, and it turns out that those cells which harbor the virus are actually quite difficult to kill. But there are drugs now, and there's actually was a recent advances made in the monkey model suggesting that if we use drugs that are being developed for cancer that induce cancer cell death, we can actually accelerate the cell death of these infected cells. So this is a whole brand new area of research in the HIV cure space, giving people drugs that induce cell death. Of course, there are potential limitations of that, side effects. These are cancer chemotherapy drugs, but we're trying to sort of figure out that balance. But this is a kind of a growth area now in the HIV cure space. Just as a sort of another side story before I get to where I think the real progress is this concept of block and lock. If we can't force the virus out, shock it out, and kill the cells, then can we force it deeper and deeper and deeper into latency? This is the block and lock approach. We can do this in mice by inhibiting the HIV TAT protein, but we've not yet been able to do this in monkeys, and we're not really close to basically doing this in people. But it is an area of active research. All right, so let me get to where the real progress is, and this is with immunotherapy. All right, so multiple groups, including ours, have been over the past 25 years trying to use various ways to induce the immune system to respond to HIV when you stop therapy and control it, mainly with therapeutic vaccines. And for the most part, and again, I think there's been 50, 100 studies that have been done in people. These studies essentially have all failed. Every therapeutic vaccine study that we've looked at that tried to actually induce the immune system to attack HIV and control it after treatment has stopped have basically failed. But now we're seeing evidence of some progress, and it's with these broadly neutralizing antibodies, okay? Antibodies, right, sort of, bind to HIV and on one side, and the other side of the antibody, the FC part, can induce the immune system, multiple parts of the immune system, to kill. So these antibodies that we've identified, which are broad acting, that can actually affect multiple different variants, appear to do two things. They can neutralize the virus specifically by binding to it, but they can also turn on the host immune system to kill the cell that has the virus. And there's now these observations that are occurring first in monkeys and now in multiple studies in people, that if you give antibodies as a therapy, as an infusion, in people who have HIV around, either when they're starting therapy, when there's still a lot of virus around, or stopping therapy, these antibodies form complexes with the virus, which we think can turn on the immune system. Right? This is the so-called vaccinal effect. And I'm not going to go into any detail here, I don't have enough time, but suffice to say that there have been now multiple studies that have shown if you give antibodies to people starting therapy or stopping therapy, that half or so, maybe more if they start therapy early, will control their virus to some degree. We often see after doing this that the virus rebounds. It goes up to about 1,000 and stays there. And some people don't even rebound. In fact, we did a study. This is it's a small study, but it's the first combination study that's been done so far. And we did a combination study. We took people on long-term treatment. We gave them a complicated approach, which has been referred to in the field as the kitchen sink approach. But we really sort of felt that the only way to make progress was through combination approaches. People got vaccines up front, then combination of broadly neutralizing antibodies. And then the first panel there on the left, and we did it in 10 people. It was a very, very intensive study. And on the far left, you see the 3 people rebounded like they should, like 99% of people do. But 7 out of 10, which is a very large proportion, either did not rebound one person or did this phenomenon that we keep seeing over and over again, that the virus slowly increases to around 1,000 and then just stays there. And this has been called the so-called post-BNAB effect. Now, 1,000, is that enough? No, I think most clinicians will say, absolutely not. I want my patient to have an undetectable virus, U equals U, and so forth, and I agree. But again, we're not necessarily targeting cure, at least initially, for people doing well. It's people not doing well, in which perhaps we can't get them to remain suppressed for whatever reason. If we can give it a simpler version of what we're doing and induce long-term control below 1,000, well, that actually may have benefit on the individual level and the public health level. So we're making progress. We're not quite there, but we're getting close. And there are a bunch of studies that are actually beginning to look at this. In terms of mechanism, it seems like what antibodies are doing is inducing a good CD T cell response, but also probably inducing a B cell response, and probably innate immune response. It's going to be complicated. We're trying to figure this out. And there are a couple studies that are actually targeting subtype C, so I don't think it's going to be in East Africa, but most of the studies that are being developed for the initially are going to actually involving broadly neutralizing antibodies are going to be targeting subtype C. But there's a bunch of studies being developed that I think will be implemented in sub-Saharan Africa over the next couple of years. All right, but long term, right, where are we going? Remember I said if we're going to have a huge impact on the HIV epidemic now and we're going to address the unmet needs, we're going to need a one-shot cure. Okay, we're going to basically need to be able to find people who have HIV who we cannot engage for whatever reason, give them a shot, and they're cured. How will that happen? Well, most likely it's going to happen through gene therapy. And what do I mean? So gene therapy basically, of course, involves using various different tools to insert genes, take out genes, enhance gene expression, fix gene expression, and so forth. I mean, multiple ways that this is occurring. As it pertains to HIV, you can reprogram CD/T cells to make them more powerful to attack HIV. We're doing this with CAR T cells. You can gene modify T cells so that they can no longer become infected. You can basically cut out CCR5. You can basically get rid of the reservoir if you can actually use gene editing to basically cut out the HIV provirus. And all this is actually now being attempted in people. We've got a bunch of studies that are ongoing in this area. We're halfway through a study looking at CAR T cells. We've done a fair amount of work trying to figure out if CCR5 disruption. I'm involved in efforts to basically knock out the provirus. All this stuff, we're at early stages, and we're moving forward. I'm just going to go into a little bit detail on one approach, which I think is the most exciting, and that's this use of vectored antibodies. Again, going back to HIV antibodies. HIV antibodies, these broadly neutralizing antibodies, can control the virus, can prevent the virus from replicating as treatment. And what we're trying to do now is to use gene delivery, using genes for the broadly neutralizing antibodies, and deliver them into muscle cells so that these cells can actually produce these antibodies indefinitely. In a study that was recently done in baby macaques, baby monkeys, where it's easier to do this, they showed that in I think 10 monkeys or so, if you gave a shot in the arm using AAV, a vector, to deliver the genes for 2 antibodies, that muscle cell took up those genes and started cranking out HIV antibodies in a stable manner, probably for decades, at such a high level that when the monkeys were taken off therapy, the virus did not rebound. Very, very exciting. And there are a number of efforts now trying to basically take this idea from the monkeys into people. And in early studies in people, we've shown that we can do this safely and we can get a little bit of antibody production, not quite there. But I think this is definitely going to be an area of great excitement over the next several years. And in fact, everyone should be aware that there is sort of a massive investment being made by NIH and Gates Foundation in collaboration to transfer all these exciting gene and cell-based therapies, which are primarily being done in the north, to the south. And in fact, I think JCRC and and other areas is going to be one of the major centers for this type of work in the future. All right, one last quick issue, diagnostics. When people are on antiretroviral therapy, they know their virus is suppressed. They know they can't infect others. They know U equals U is at play. That's really important. If you're on immunotherapy, it may not, in fact, actually be so clear-cut as to whether or not your immune system is working, because it can fail and you're not going to know about it. And so, in addition to developing all these cure interventions, there's a massive effort underway to come up with a way to measure the virus at home, right? I think that's going to be a critical part. People who are basically in some kind of cure setting don't 100% know on a day-to-day basis whether or not it's working. They're going to need to know their viral load when they need to know their viral load. And so there's a lot of effort going on to develop these at-home testing. Pinprick, boom, 15 minutes, you know, yes or no, the virus is there. All right, so in conclusion, I didn't go into this, early antiretroviral therapy can cure infants. We've seen that, but not adults. The shock and kill approach remains somewhat promising with some progress in monkeys, but not yet in people. Same with block and lock. Most of the exciting stuff is around immunotherapy, particularly around these broadly neutralizing antibodies. And in the future, it's really going to be all about cell and gene-based therapy. Again, I apologize for not being there, but I should be available for questions. Thank you.
Thank you very much, Professor Steve. All those that have questions, please keep them. We shall be having another session, the last session, for question and answer. But we'll have one last presenter. She's going to talk to us about transition from pediatric to adult HIV care. She's our friend, Dr. Sabrina Bakera Chitaka. She's a Ugandan medical doctor with a specialized training in pediatrics and child health care, as well as pediatric infectious diseases and adolescent medicine. She's a senior lecturer at the Department of Pediatrics and Child Health at Makerere University. She was a Gilead Fellow and then research scholar at the Infectious Diseases Institute. She has earned a PhD from the School of Biomedical Sciences at the University of Antwerp, Belgium. She's involved in conducting basic research in various pediatric infectious diseases and offers clinical care to HIV-infected children and adolescents, most of whom are perinatally infected. Dr. Chitaka is an active member of the African Pediatric Society of Infectious Diseases. She's an author of Real Pursuit of Excellence. She is a wife and a mother. So we are eager to hear from you, Dr. Sabrina, if you're online. IT.
Thank you very much, Dr. Tamale, and thank you everyone for having me. I know it's at the end of the day and at the end of the week, but I'm delighted to be presenting at this update meeting. And thank you very much, Professor Steve, for your enlightening presentation. I have just 10 minutes, and I'll be very quick to summarize this. We know that there are nearly 1.8 million adolescents living with HIV. The majority live in sub-Saharan Africa, and the majority are women. But also, we have heard all throughout these last 3 days that HIV is a virus. It attacks the immune system. If it's not treated, it can result in AIDS. And we would like that everyone is able to prevent death from HIV. This is just a basket that contains what we need to do for these adolescents as they grow up into adults, that we must have a comprehensive, properly resourced sex education for all, supporting their gender identities, having healthy relationships, good mental health, and also spiritual wellness. And this will flower into open and honest communication, joy, mutual aid, and trust. Like I said, the HIV positive patient is usually a female, and the HIV adolescent clinic at the Baylor Clinic was started in August 2003. We know that most of the adolescents are vertically infected, some behaviorally, and they are from various backgrounds. Some are in school, some are not, some are employed, others aren't. But these are key areas that we must all look at as we talk about transitioning. That it all starts with treatment initiation, ARV sequencing, simplification strategies, monitoring their treatment, and supporting them to adhere. And that we start with testing, enrollment into care, and then the lifelong treatment. I already shared this slide, but it just shows you how, through our psychosocial support clubs, we are able to transition our adolescents from being in the kids club to the shop club to whenever they grow older. And our curriculum has a lot of self-empowerment skills, including growth and development, how they work with teasing and self-defense, coping skills, and all that. But what is transitioning? Clearly, as adolescents become adults, it's important for them to transfer into adult care settings and be able to be responsible for their own health and disease management. But this may not necessarily be possible in our setting. But why should we transition from the pediatric service to the adolescent clinic to the adult service? One is to enable these adolescents to be independent in their care and treatment. And in order for us to set this scene, it's important to know that by the age of 18, 42% of urban and 50% of rural adolescents may have become pregnant, their birth-related complications, and adolescents living with HIV are those that are going to live longest on antiretroviral therapy. So, if a child is born with HIV, what are some of the complications? What are some of the problems? We know that there will be neurocognitive delays, there's physical and mental health problems, there's antiretroviral therapy non-adherence, and adolescents are the ones that are continuing to die because of non-adherence. There's low retention in care, I already mentioned mortality, and more likely, interpersonal or interpartner violence. So as adolescents grow up, they become pregnant. This image here, I was impressed by it because it just shows you exactly what happens. Pregnant baby, mother breastfeeding, and that adolescents continually be the ones who continue to spread HIV to their unborn babies because of non-adherence. And as we look at all this, the different strategies, we need to look at the baby that is born to this HIV-infected adolescent and ensure that prevention of mother-to-child transmission happens, that adherence continuously happens, and that even the structural and socioeconomic issues are supported as we talk about transitioning. We cannot negate the fact that mental health challenges can affect any adolescent, whether male or female, when they are pregnant or when they are planning to deliver. And these mental health problems include anxiety, trauma, suicidal ideation, and even suicide. But we need to support these adolescents to be resilient. We cannot forget about the adolescent fathers. These are usually the forgotten half. And even though men are mature, they seem to be confident and all that, they too need support. And if they are not educated, if they have a multiple series of sexual partners, then they are going to have poor prediction of success as they grow into adulthood. We need to let everyone know that being a young mom is not a crime. And this is just the story of Miriam. She's an imaginary individual in South Africa. And we need to focus on the individual, that children having children obviously is scary, and children having children and young grandmothers becoming grandmothers when they are still children is a challenge. But there are some success stories, and there's an evidence gap where they should go and also how they should be prioritized when we are gathering this evidence. There are many problems of adolescent parents, and we know that when people become sexually mature, they'll end up getting pregnant and having children of their own. But we need to stop this situation where there are so many adolescents who have not gone through school, who don't have work, because they are going to become a dependent population. We cannot forget that as we interview these adolescents or young adults, we have to take them through the HEADS assessment. I will keep singing about this HEADS assessment until every single healthcare provider understands what it is. Because if we don't ask them about their home, about their eating, their activities, drugs, depression, their safety, sexuality, suicidality, they may be at risk of dying. So really transitioning encompasses more than physical transfer to a new clinical location. It requires us managing and adjusting to a new organization of care, whether in the same place or with new care providers, and also a change in the level of personal responsibility and family responsibility in care, and also a change in patient and provider communication. So these are just a few studies. Julian and Coraja did a study on transitioning at different TASO sites to identify gaps in provision of effective adolescent and sexual reproductive health. And we found that there were very minimal strengths in every area in the country, that healthcare providers were not well equipped to transition these adolescents into adulthood. So what are the key issues when we are regarding transitioning? One is that it's not just about changing doctors. Two, if these are young patients and they need to take control of their own aspects of healthcare, they need to be told that it is possible. We start with, as a child, they cannot do it, they cannot take their own treatment, they have to be given the treatment by either a grandmother or a parent or whoever, until finally they are adults. Yes, they can do it, they can time their own treatment, they can relate, they can have, they can get married, they can have jobs. And it doesn't matter how small these adolescents are, whether they are stunted or they have growth challenges, they need to be supported to, one, take all their medication, but also to transition from being young adolescents, middle adolescents, until they become adults who are able to transform their society. So we need to equip them with skills that enable them to be confident, that enable them to scale up on education, especially sexuality education, to be engaged, such as the YAPs, to be involved in improving their own service delivery through participating in national policy, guidance and training, and then finally reaching out to other adolescents, especially those in school. This is just an example of a policy brief from the WHO that enables or encourages each of us to be educated in how to take care of these adolescents and also to do studies in transitioning. So to all of us listening in today, there are areas for programming that we need to strengthen. The first one is in leadership. The second one is in adolescent participation. And if you request for an adolescent to participate in your program, please budget for them that they will also be paid. And then we need to finance adolescent health priorities and build an adolescent competent workforce at all levels of care. These levels of care may be at home, they may be in the community, they may be at health center 2s, 3 or 4s, but even at the centers of excellence. And that, at the end, we must prioritize quality and service delivery platforms that maximize coverage for these adolescents as they go into adulthood. We also have to plan for the data, that if we do not know how many adolescents are young adolescents, middle adolescents, late adolescents, how many are going to become adults, in our health management and information system, we won't be able to plan for them. So, just to summarize everything I have said, transitioning is a must. adolescence in its own self is a transition process, a process that is not permanent, but is a process that enables this adolescent to move from being a child to becoming an adolescent and then becoming an adult. And we as healthcare providers, we need to know how to respect them. We need to understand how not to be judgmental. We need to respect their dignity and also understand adolescents as change agents. At the end of the day, we would like that the knowledge we have garnered is knowledge we are going to use as these adolescents become adults and as they become geriatric patients. We know what to do. We know that we can prevent age of sexual activity. We know that we can talk to them about condoms. We know that we can talk to them about reducing their age disparate sexual partnerships. But also it's critical to focus on content other than quality. We've heard throughout this meeting that there's been a lot of science that has come through to ensure optimization of drugs. Yesterday, we had a discussion where we were looking at the number of adolescents increasingly switching from first line to second line to third line. But we have hope. From what Professor Steve presented, cure science is not about to happen. But we have hope that as we transition from being basic scientists, we shall become those scientists as well as a holistic doctor who doesn't only look at the patient as a patient, but looks at the patient as a change agent. Thank you for listening to me and have a good evening.
Thank you very much. Our senior pediatrician, Dr. Sabrina Chitaka. We've come to the end of the first session. I think you've been shelving your questions. I'm handing over to the next session chair to make sure he coordinates all the questions and answers. Our next session chair is Dr. Francis Kanyike from JCRC.
Yes, thank you, Dr. Tamale. Wow, it's been a wonderful evening, and I'll stand. This is the part I love the most, doing the open discussion, because here we get the opportunity to interact with you, and now you become the content experts also. So feel free to share your opinions, your thoughts, any lived experiences, questions. We still have our content experts in the house. Others are online. So here, it is your turn now to, we want to feel you. It's been 3 days of amazing presentations. We had several content experts. We had updates from international conferences. We had updates from PEPFAR. We had sessions yesterday on HIV vaccine. We've had several sessions on HIV preventions, including injectable ART. Today, Dr. Sise just shared exciting presentation on long-acting ART. That's exciting. Dr. Sali has presented the roadblocks. We've had a discussion on resistance, and we've also had interesting presentations from Dr. Steve on HIV cure. So this is open. The online audience has... You're putting up your hand? Hey, I'm going to allow you. Hey, but I am the session chair. Dr. Sise is my boss, so when she interrupts, then definitely I have to. Yeah, but I love this session. Like I said, I want you to share your feelings, your questions. Dr. Sali, I had questions for you here. I've been writing them from the online, audience. It was exciting about the roadblocks. Dr. Tamale is going to support me with the audience.
Yes. I'm ready.
Yes. So you're ready?
Yes.
Please go on.
So we have some of the questions that have been asked, and I think Dr. Sise had the first question. So she needs to answer it.
Thank you. Thank you to all the presenters and those ones that are online now for giving excellent presentations. I have several comments and questions, but my first comment is to on Steve's presentation on HIV cure. Thank you again for an excellent overview and where the science is going. I think for us as researchers, this overview in just a few minutes should be inspiring for the researchers who are here. There are many strategies that are being pursued, and we should be part of that pursuit or that race and contribute to HIV cure, because if we do not get involved in HIV cure research in our populations, we will not get the access. We will get the access many years after. So this is to encourage the researchers here that you have gotten a wealth of information, and I hope the presentations as PowerPoints can be shared with us so that we can share them with many people. Many people are online and they are listening very attentively. So thank you very much. But I had some comments about even when the cases were presented. I know there are healthcare workers in this room. How much training or refresher training are we getting in the management of our patients? Because I think we are mismanaging the patients. Just from one case that was presented here, but what more is happening out there? And of course the ministry is not here, but for us, when we get these as part of next steps for this meeting, what training and refresher training are we giving? Alison talked about resistance. People should be able to read resistance. What training are you doing to provide healthcare workers with these skills? There was a question on screening for depression and neurocognitive disease, but how widely are we using it? It's not only patients in HIV who are aging. We have started to roll out HIV in 2004. So there are many patients who are for a long time on antiretroviral drugs, and they are aging on antiretroviral drugs. But what are we doing and this goes back to you, Dr. Sally, we should be helping the ministry to lead and see how we can improve health care in our patients, but starting at JCRC. And please, I want you to write that publication on these cases. It is very important. It should not stop at presentation in this meeting, but we should write it up and publish it, because maybe there are many more cases that or many other healthcare workers we could inform, not only in Uganda, but other places. Then, Alison, you talked about 20% DTG resistance. Please, we have to be careful. This is not a national survey. This is a very biased sample that has gone to the lab. So don't translate 20% to the whole of population of Uganda. And we should understand this. And when you present next to your next audience, put this in context so that people don't take away these alarming figures and think that we have 20% resistance in the country. And the care and the pediatrics, the transitions, Dr. Sabrina, Bela is a center of excellence, but where else again are you training, or how are you helping the ministry to help other institutions do a proper transition? Because we may not be as detailed as what you're doing in Bela, but I think for the most part, we just send the patients to the adult clinic. You are of age, please move on. Yeah, thanks.
Thank you so much. I'm sure they've been listening. So who goes first? Dr. Steve? Dr. Steve, are you online?
Hey, everybody. Yeah, hey, everybody, I'm here. You guys, okay?
Yes, carry on. Dr. Sisse had comments for you in the questions.
I heard Sissy's comments. I didn't hear a question. I think she asked if I could share my slides, which of course I can. Sissy, did you have a specific question for me?
It was a comment to these people online and in this room that you have given a very broad overview of what is happening, and researchers don't sit back after this meeting and wait for next year. Take some action and do some aspect of research on, because ultimately, I think our goal is to get a cure. Even if we are talking about long-acting ART, and I think you've had the cases, how challenging they are in the way we are treating HIV. It was a comment, Steve.
Sure. I mean, as you know, Sissy, there's, massive amount of a shift in the way that we're going to be conducting cure research, essentially moving the agenda from the north to the south, where most people who need a cure live. And so within the ACTG, within the Gates Foundation, NIH funding, there's going to be ample opportunity, particularly for early stage investigators, to get involved in HIV cure research. There are a number of programs, number of grant opportunities out there, and so forth. And I'm happy to help any way I can.
Yes, thank you. Let's clap for him. Thank you so much. Now, Dr. Sally, you're going to respond to the comments, but also you will do this question that was asked by John Paul. Was there a higher viral load in CSF than blood for the cases presented? What could be the explanation? Have we considered that drugs are not crossing the BBB, that is the blood-brain barrier? Any possible causes? More insights on that as you respond to Dr. Sisse's comment.
Yeah, thank you very much. Maybe before I answer that question, I also like to, let me also answer a question that was raised by Alison when he said that we are seeing a trend in lower resistance to TDF, lower resistance to AZT compared to what we had before. And yet we are seeing some rise in the DTG. My thinking about that is because these medicines, these molecules were previously not as well protected as they are now on DTG. And with the DTG combinations, it's more difficult to get resistance to these molecules. So it is protecting them, but it is not being sufficiently maybe protected over time as we go on. So that's why we are beginning to see some increase in the DTG resistance. And just again to double down on what Dr. Sisse has said, because you showed that we have about 96% virus suppression. And that means that the patients, out of 100, the ones who are not suppressed are 4. And of those 4, about 75% plus don't have resistance. So that means 1 out of 100 people that we are treating may have DTG resistance. Of course, it is worrisome that because in the past we had none, but now we have something, we really need to protect the drug. And again, as it has been mentioned, we need to make sure that we adhere to our guidelines very well to protect our medicine so that our patients do well. And in regards to the CSF, higher CSF in the higher viral loads in the CSF compared to plasma, yes, that's what we saw in those patients. In 2 of them, plasma viral loads were below 50. And in 1 of them, the viral load was like 2,000, but, like a fold increase in the CSF. And I think maybe because that compartment naturally has a blood-brain barrier that that stops noxious substances, anything foreign from getting there. But I think in this case also there's some impact on the drug. So it may be possible that we don't have as much drug in the CNS as we have in the plasma over time. Perhaps in the short run it may not be quite a deal, but over time it might.
The publication.
The publication? Yeah, we will, I think we'll write up these cases. We've also had some discussion with one of the psychiatrists, Dr. At UVRI, Dr. Dr. Chinyanda, Eugene. And he's also thinking was that, you know, we will need to write up these cases so that we can use them to get a bigger grant to look at, you know, the entire extent with good tools that we can then eventually use as recommendation to the MOH.
Thank you, Dr. Sally. Dr. Sabrina, online, do you have any word from the comments raised by Dr. Sisi?
Yes, I really appreciate Dr. Sisi's comments, and I think that it is important to train not only pediatricians or people in the in-service area, but in the pre-service. Here at Makerere University, we train all our undergraduates on adolescent health. And I'm glad to say that even for our postgraduate students, we are now giving them an entire 6 weeks course in adolescent health. That way, they're going to become like a ripple effect. I know that at Mbarara University, they've also started to train their undergraduates. And so that if all the different 11 public universities, or even the private universities, understand that adolescents are a unique population, that their care and treatment should be managed differently, then we are good to go. The other thing I'd like to say is that we all need to be aware that adolescents are a unique population. That one, they are not big children, they are not small adults, they are adolescents. And that our knowledge in managing adolescents with HIV should go beyond the confines of treating HIV-infected individuals, but we should use the same knowledge for caring for adolescents and children with chronic diseases, like sickle cell anemia, like diabetes, like asthma, like any other, but also managing adolescents in our country. I could go on and on and on, but help everyone understand that the average age of Ugandans is only 16 years, and that if we as healthcare providers, as parents, we don't know how to manage these individuals, then we are doomed. We need to support them to transition through the period of adolescence, but also to become responsible adults who will not only survive, but thrive and then transform their societies. Thank you.
Yes, thank you, Dr. Sabrina. I'm going to come to the audience. Dr. Sally had forgotten a small comment on CSF.
No, actually it wasn't CSF, but the point of the adolescents, we're not seeing only poor outcome in HIV in that age group, but in sickle cell we're seeing very high mortality among you know, the latter years of adolescence. I don't know what Dr. Sabrina puts as a cutoff for adolescents, but we've seen youngsters in their early 20, 19, 20, 21. The mortality in sickle cell is very, very high. And that's the time when the parents are, you know, they are happy that the individual can take care of themselves. So I think we just need to help these individuals better.
Dr. Sabrina? Is she online?
Yes, indeed. We really have to see how best to take care of these adolescents, that they should not be stigmatized by the diseases they carry, including people living with sickle cell disease, people living with HIV and other chronic diseases, that we need to start supporting healthcare providers in every single field, the counselors, the social workers, the pediatricians, the physicians, that if, for example, a child with sickle cell disease becomes an adolescent is 10 to 19, young adult is up to 24, but our youth is up to 34 in this country. We all need to learn to treat them with respect, to encourage them to adhere to their own medications. It is so painful, like Professor Sally has said, that if we manage to help an adolescent survive, we shouldn't lose them in their third decade of life, which is 20 to 30. We need to encourage them to be responsible for adhering to their own medications. That as long as we do not learn how to take care of them, we are going to lose them. And it will be very painful, not only for the parents, but even for us as providers. So let us learn, and let us support them correctly. Thank you.
All right, thank you, Dr. Sabrina. I'm coming to the physical audience, but I'll read 2 questions for Dr. Sise from the online audience. Akanchunga Dixon was wondering whether there is a backup to the injectables. Second option in case of resistance. And then another question, you're taking notes? Yes, good. Another question from Anonymous, they didn't share their name. They were wondering whether there will be cases, it's actually similar to the first question, whether there will be cases where clients will be reinitiated back to the old regimen in case we get resistance from the long-acting.
Before Dr. Sise, there's another question for Dr. Sise here.
Yeah, I think this is just to re-echo the question I had earlier. 2 of them still revolving around efficacy and resistance. One was a concern about the rollout of injectable PrEP, where we've had, to be specific, injectable cabotegravir for PrEP. Given what we normally see about the misuse and non-compliance on PrEP, doesn't this pose a fear for future resistance to our long-acting ART injectables? Then secondly, from the CARES study, it was mentioned about the baseline characteristics, specifically from the PBMC studies, that almost, I don't remember pretty well, but it was around 74, the percentage of those participants who had had prior exposure to NNRTIs, where rilpivirine could fall. So, and then the noted archived mutations. So the efficacy we saw with these injectables of rilpivirine and cabotegravir, do we assume, or how do we be sure that it wasn't a cabotegravir monotherapy and the rilpivirine was not really as efficacious? Yeah, so that was my question.
Okay, so we shall have them answered, and then we have another round in-house.
Thank you. Dr. Patrick, I had your questions here. I did not forget. The first one is about PrEP, using cabotegravir, and then possibility of using the same drug, of course, added to another one in treatment. I think that is a real possibility, and many groups are discussing, although the breakthrough infections that have been seen on PrEP are few. As you roll out, there could be more. And the discussions currently for cabotegravir and rilpivirine are for people who are on stable, doing a switch study like we did in CARES. Patients had been on treatment for 8 years. Or for those patients who have had serious adherence issues, but I think your concern absolutely is something that people are thinking about and discussing. I do not have a definite answer right now, but you can actually join these discussions. The second one is about the exposure. It was 74.2, and then baseline resistance to reprievrin was about 13.5. And your question is, aren't we giving people monotherapy cabotegravir? We've not demonstrated anywhere that monotherapy cabotegravir is effective and efficacious and can give you 97% efficacy after 48 weeks. So possibly not, but what we are looking at the resistance that we have seen, and there is a possibility, this is archived resistance, and there is a possibility that maybe it is defective and it will not translate into actual resistance. We are working with virologists to look at that data that we got. You also asked about injectable fatigue and then oral bridging. I think that is what is coming up in the other questions online. The participants who failed on cabotegravir and reprievrin in the CARE study were transitioned back to TLD, and they are doing very well. Although some of them had low-level resistance to dolutegravir, they are doing very well. We did not double the dose even of dolutegravir. They are doing very well. But within the study, we had people travel. Some people had to go for business, others for studies, and what we provided was what we call oral bridging. So instead of taking the injectable, they took oral cabotegravir and reprievrin tablets. But oral bridging could be done with TLD. It is the same effect. It is, a combination. So that possibility is there. And yeah, I think I've answered.
Yes, thank you, Dr. Sise. Dr. T, let's give Alston to respond to the comments that were raised earlier. Yes, Alston, please go ahead.
Yeah, thank you, and I think these were very objective comments from Dr. T. The ministry, and we have the privilege to have Dr. Jen here and Dr. Sally. There is in regards to what are we doing to train, to skill the healthcare worker, there was a national HIV DR training curriculum that was developed with the support from Dr. Jen and Dr. Sally, and that has birthed the teams. I think you're seeing here, we're seeing Dr. Fairuz, the new young blood that are running the programs at national level, but now transition to the regions. And we are seeing the regions are doing a great job skilling the other healthcare workers through eco platforms. Now, more than ever, now we are using digital systems, and we have at least a national HIV drug resistance database that we never had before. Right now, when a clinician receives an HIV drug resistance result, they sit at the clinic, look at the patient history, they suggest possible directions in terms of whether they should switch a patient, substitute a drug or two, or maintain the patient on treatment. Now, when they do that, they do it in a system. Now, that system, when a result, when the regional team meets to discuss, they score these clinicians or these facilities in capacity to make the right decisions. Over time, what we are going to see and what we are going to use is to evaluate that data and start winning off as many facilities as possible, such that now it's decentralized now to facility level, but we shall have data in the system. In regards to the presentation, I think you're very right, getting it in context. Somewhere I mentioned that this was acquired, but there's a study, it's called CADA study we're doing with the UVRI team, and I know JCRC is also part. that does the surveillance regardless of whether someone is, for as long as you're non-suppressed. So it takes in those that have done ISC, those that haven't done ISC. And for that, the last data we saw that at least DTG resistance was like around 5%. We haven't seen the other results from CADA2, and we are waiting to see what's happening. Thank you.
Thank you, Alston. Dr. Tamale, we have a hand from in-house. We actually have more hands in-house. Yes.
James Opeda, I'll shield Dr. Sisa since she's the only gentleman in the house, and I'll ask Professor Steve and probably Dr. Richard. Will the US continue funding Uganda in light of the laws that we passed? Aware that 21st January is coming through. A few days ago I was in house with the US ambassador to Uganda, and the same question came up. And he was cagey about his answers, and we are concerned. Because we're looking at issues of sustainability, and we could easily roll back in terms of the efforts that we've made. And the other one to Professor Steve, all these efforts that you're making, we don't see any vaccine coming through. Now you're talking about a cure. I think they're all yielding the same result. They're all intended to fail. The objective is that right now, Dr. Sis and her colleagues enjoy a share of about 1.5 million people on antiretrovirals. And you would require to continue enjoying this market. Question is, are you really serious about a cure and a vaccine? Thank you.
Thank you so much. Dr. Steve?
That's Muzei Opeda.
I didn't understand the part of shielding Dr. Shishe, but Dr. Steve, are we online?
I'm here. Can you guys hear me?
Did you hear the questions?
I heard the first part pretty clearly, and to be honest, we have a lot of concerns here in the United States as what's going to be happening in terms of funding for HIV-related research and care. It's my understanding, as it pertains to PEPFAR, that has got universal support, bilateral support. In fact, it was developed under a Republican administration, and in the Senate there are many powerful senators who are Republicans, you know, Trump's party, who are very, very supportive of PEPFAR. I think that there's going to be a lot of changes in terms of research support internationally and educational stuff, but I'm hopeful, as are many of my colleagues, that PEPFAR, which I think is providing the bulk of the support for care, for treatment, from the U.S. perspective, that's going to be relatively safe, but no one really knows.
So this is Frank Rave. I don't know if you can hear me or not, but I think this issue is your best argument for finding cures, because sustainability of the drugs is expensive, and cure could be a much cheaper way of solving this problem.
Yeah, I mean, although when clinicians think about cure, right, they think about what their patient wants. You know, earlier on there was a lot of discussion about pill fatigue, which is real. It's hard to take these pills or these shots for decades and decades, and so the people really want a cure. But that's, to be honest, that's not why people are funding cure research. People are funding cure research, as Frank said, the public health perspective, that, you know, one shot, you know, done and you're cured would address all these concerns about PEPFAR and funding. And so Gates Foundation and NIH, they're really, this is why they want to fund a cure, because of these concerns.
Thank you, Steve. Before you actually leave the platform, there's another question for you here. What role does AI play in predicting immune responses to HIV cure?
AI is a big deal right now in science. I know that you know, the HIV diversity is just so massive that developing vaccines and cures that can, you know, tackle the diversity of the virus population that's spreading, that's a major area in which AI is being used, and I'm sure others, but it's not really my area of expertise.
Thank you. We have another question from the audience. Yes, please go on.
Thank you so much to all our presenters, really innovators. Dr. Sisse, while you were away, we had a lot of malnutrition issues coming up, escalating within the research. And as a reputable institution, JCRC, remarkable nationally, how can we partner to see that we address this issue of malnutrition with some research and see how we can complement HIV programming in the country? Then also, Dr. Diana also hit the rock when she said that where are we in climate change that is being challenged, that is challenging our HIV approach and best practices. If you can agree with me, we've been facing several landslides and floods. What do we know whether the floods will take away one of the joint clinical research center within somewhere, and the clients will get lost? How will they be followed up? What are the mitigation measures in place that respond to smart climate change programs? And I'm not saying that this should happen, and actually my prayer is that the mitigations are in place by JCRC. And research must be also developed around climate change programming. Then also, Dr. Sabrina Chitaka, thank you so much for the best practices. But I also need to learn from you whether we have wellness activities for the adolescents living with HIV within their area of living to overcome the stigma and discrimination challenges within their living. And also, how do we handle the households and caregivers of these children to understand that they are also children, they can also deliver, they can grow up and be like you, Dr. Chitaka, and deliver and serve the country, so that they don't just abandon them and throw them away because they're infected and they are useless. To some homes, they take them to be bastards, you know? And yet, we've had several ones of them. Even today, we have some sitting on CCM, National Global Fund CCM, Positive Living People, and they are giving very good views to the country. So how do we help these young people, take them into wellness activities, and they really feel they are loved and they are part of us, they are with us? Then to Dr. Stephen, I need to learn from you how cost-effective this gene therapy to us, the positive living persons. Thank you.
Thank you. Dr. Sabrina, quickly. I don't see Dr. Diana around, but I know Dr. Sabrina is online.
Well, I'll just say that we all need to understand that food is medicine, and that if we understand that food is medicine, we are going to start with us as healthcare providers, eating a balanced diet and training our clients to eat a balanced diet as well. And that a healthy and balanced diet starts from even before a woman becomes pregnant, as she prepares to carry that baby. You know, the first 1,000 days, for me, that's a topic I talk about a lot. But regarding climate change, I know that it also relates with food. If you have floods and catastrophes of landslides, then the people who are going to be most affected are children and women. That men can fend for themselves, they can travel and go away, but that we should all work together through the Sustainable Development Goals and ensure livelihood and ensure universal health access to health. But also, the specific question I was asked was about wellness. Wellness includes beyond taking medicine, but having a positive attitude towards life, exercising, having a healthy sleep hygiene, and generally being confident in your skin. So how do we train healthcare providers and parents and caregivers? We've gone beyond just talking to doctors and pre-med students, but also talking to parents teaching about positive parenting, talking to teachers and school nurses about how to instill confidence in the adolescents. How do we encourage them to do sports? How do we encourage them to sleep for more than 6 hours? How do we encourage them to eat a balanced diet? So there's a lot that we can do together, but we need to know that these adolescents come from homes. As healthcare providers, we are not always with these adolescents. So we need to support the healthcare the primary caregivers who are the parents on how to respect these adolescents, motivate them, keep them in school so that they become the future, the people you talked about who are sitting on our country coordinating mechanism platforms. Thank you.
Thank you, Dr. Sabrina. Dr. Steve, you're online. I had a question for you.
I think the question was about whether or not, would the cure be cost effective? And of course, that's an important consideration, and there's been a couple of modeling studies have been done based on the cost of delivering care lifelong. In actually one study I know in Zimbabwe, they looked at how much it would cost to treat an individual for life with antiretroviral drugs and viral load monitoring in Zimbabwe. And then asked the question, okay, you take that amount of money and you put it in a cure for that one person, how much should that cure cost? How much can it cost to make it worthwhile? And the number came out to a couple thousand. So one study looked at about $2,000 US, and another study said it could go up to around $4,000 or $5,000 US. Certainly the cures that I was talking about, particularly some of the gene therapy approaches, if you look at the actual cost of the goods, that's definitely achievable. In theory, some of these one-shot cures could easily be well below those numbers at scale. So, hope that answers the question.
Thank you. Thank you, Dr. Steve. Dr. Frank, you're online. There's a question for you from the House. Is he online?
I'm here.
Oh, good. So there's a question here for you. Does smallpox vaccine work in monkeypox? And before you answer that, Dr. Siso also has a question for you, so you can do them together.
Thank you, Frank, for always giving us insightful presentations. And for the rest of the team, it was Frank at one of these update meetings who talked about HIV cure and CRISPR. And I followed up with Frank, and that is why we are where we are at JCRC with the HIV cure agenda, because he excited my mind and I wanted to follow up. So you did make a presentation on Mpox and Marburg. And these are some of the emerging infections. And what we could continue the conversations outside of this meeting, but what should we be doing in terms of targeted research to address these emerging infections? From your experience and your networks and collaborations, what should we be doing here? I know at JCRC we are developing a diagnostic PCR-based for Mpox so that we do not have to import reagents or some of the reagents. But what is your view? What do you see? Because you are more exposed. What could we be doing as researchers with respect to emerging infections?
Thank you very much for asking that question. Before anything else, I have to just comment on Dr. Sabrina's wonderful presentation. We need you here because in my experience, very few people get through adolescence without developing resistance, and it's almost always when they do it, it's because they've had a very attentive mother that has had a cooperative relationship with the daughter. We've not succeeded in by ourselves in getting them through adolescence without resistance. It's so good to see you again, Cece. It's good to see you, Francis. That's wonderful. The smallpox vaccine question actually was answered. One of the original studies done of Mpox clade 1A, now we would call it, the study was done by offering a reward for people with Mpox to allow to report their illness to the study doers, and that group then monitored the families for transmission. And that was the first study that showed that human transmission wasn't very common. There certainly were some one-generational transmissions. There were a couple of two-generational transmissions. I think there was only one three-generational transmission. So that showed that there was not a lot of human-to-human transmission with the original ones. And the strongest correlate in that study of whether or not the family members got Mpox was whether or not they had previous smallpox vaccine, which at the time that study was done, it was about half the people who participated. So how do we manage that in the future? I wish I knew. That's the wonderful feature of infectious diseases. We have a world of bugs out there evolving to make a living from us, and it is clearly the least predictable of all subspecialties in medicine, and that's why it's intellectually delightful, although sometimes quite challenging. Thank you.
Thank you, Dr. Frank. Thank you, audience. You've been a great audience. We are coming to the end. We are going into the closing remarks. It's been exciting, and thank you for enduring. There's tea. Please don't go away. So right now, we are going to have closing remarks in this order. We are going to start with Dr. Sally. Then we shall have remarks from Dr. Frank. And then finally, we shall seal it with Dr. Sisi. So I'll start with Dr. Sally, but as you take your podium, and before you give the remarks, there is a question for you. Actually, this person, Bugembe Robert, kept texting me that don't let Dr. Sally go away without answering my question. I think he's a clinician and he has a patient, a 37-year-old male patient at Masindi Hospital, who they started TLD in less than 6 months. The patient developed neurological issues, degenerative symptoms with multiple focal lesions on CT scan. So he's wondering whether CSF viral load is recommended in this patient. So Dr. Sally, please. Yes, sure. Take the podium.
Good evening, everyone. Those of you who are here and colleagues that are out there online. Maybe just to briefly say, the cases that I presented, those were already in long-term care. They were not individuals starting therapy. I think when one is starting therapy, it's possible people have virus everywhere, and they may have OIs. If there is an investigation maybe for viral encephalitis, I would indicate it, or an indolent meningitis, maybe yes, but not necessarily for HIV, because he has not been on therapy, and the chance that he may have maybe drug resistance may not apply. It's just 6 months into therapy, maybe after 1 year into therapy. Yeah.
Thank you.
Yes. So now as we come to the end of our meeting, I just want to thank the organizers of this meeting, some of our colleagues who have been speakers of this meeting were also part of the organizing group, Frank has been there. We had meetings, planning meetings. Frank, Richard Elion, who was here yesterday, Ian Gilson, and Michael Madalon. Michael didn't make any presentation, but I hope he was there online. And I just want to thank also the speakers that we've had, speakers that came from Uganda, and also the speakers who came from abroad. I really want to thank you for enlightening us and educating us in this meeting. And I also want to thank the program chairs, the session chairs. You did a wonderful job. Some of you are from home at JCRC, but many of you are also from other institutions. Jane and others, really I want to thank you very much. And also part of the organizing team that was here, Nelson and group, and also the colleagues that supported the professional team that supported us with the IT systems. So maybe we just give you a hand clap. As we wind up the meeting, I'd like to inform you, please, there's an evaluation. It's an online evaluation. Do fill it about the meeting. It helps us, it gives us feedback, and also helps us to make your experience next year a lot better. And also it will help you, I think, to get an e-certificate for CME for this meeting. And please remember, I think maybe the IT team will tell you, a lot of these sessions that have been presented, there are some sessions you may have missed yesterday when we had 3 concurrent sessions. So after some time, I think they are going to upload them. You should be able to access them in the platform. I think they'll give you a link. Juliet, is the current link that you gave people, will it be the same that they use to access those sessions? Okay, so it's yes, affirmative. So you should be able to access them. They'll be on for some time. So I just want to say thank you very much, and good evening, and good morning for our colleagues in the US. Yes.
Thank you, Dr. Sari, for those insightful closing remarks. We are lucky that we have him at home. We disturb him anytime. Now, let's have remarks from Dr. Frank. Dr. Frank?
I'm here.
Oh.
So I sent in a 2-minute recording that talks about, that shows all the pictures of the course of the development of this course. I don't know if you can roll that or not. I just wanted to add this to my remarks because Frank Graziano was a delight for us all and a great fan of Uganda. So I just thought I'd show his picture and show the way he worked the crowd when we had a meeting. He loved to walk up and down the aisles and talk to people. He liked getting up close to people. And we've been doing this for a long while. So this is our first talk, our first meeting back in 2008 in Tevi. At that time, we had more to offer you than we do now. We'd all been at this since the 80s, and you hadn't really got into it until PEPFAR gave you enough money to give drugs and to formulate some structures to give those drugs. So here's how it went. We didn't have anything, and that's the 2008 group. Here we are. I had more hair then. Here's what it was like in 2010. We skipped 2009. Here's the 2010 group, and the 2011 group, and the 2012 group, and the 2013 group. Here we are again in 2014, 2015, 16, 17, 18, 19. So this is a great structure. 2020, of course, and the next year we were all remote because of COVID, and we'll hopefully have many more of these.
Wow. Thank you.
So probably for me, the most gratifying thing about this wonderful experience is the maturity and the strong development of people in Uganda and all of Africa, in fact, at caring for people with HIV and doing research on it. It's remarkable how far you've come in that interval. We're kind of legacy right now. When we started out, we'd been at it for a while, and you hadn't, so we had more to offer than we do now. But it's nice you still let us come by. Thank you very much.
Wow. Please let's clap like we appreciate it. Yes, thank you, Dr. Frank, for those thought-provoking remarks. I love the pictures. Thank you for archiving them. Some of them were in this very place. Wow, that's interesting. All right, so now let's have Dr. Sise. Dr. Sise to give us her closing remarks.
Good afternoon again. Today I do not have a video to show, but maybe next time. We are all very thankful to Frank Graziano, whom you saw. He's been working with us. Now he's deceased. He worked with us from the time we started rolling out antiretroviral therapy in 2004. And then he used to come maybe 3 times in a year, and we would do these regional trainings with our different regional centers of excellence until we consolidated this into one HIV update meeting, which has extended beyond HIV to include issues of public health importance. So, and when he died from cancer, and when he was dying, he did leave us with some money to continue these meetings. So we are very grateful to the team that he worked with, which include Frank, Richard, Elion, and Michael. They used to come, yeah. They are really volunteering to support us. And they used to come physically until COVID. Then after COVID, we didn't have enough resources to bring them, but face-to-face is more than Zoom, but that's what we have today. A big thank you to our presenters, both international and national. I think the quality of the presentations is really great. The learning is, you can clap for them. The learning is great, and all within one half-day meeting for 3 days without any pay. Who gets that for free? So we are privileged, and they give us the latest updates on what is happening in the world. And I think they've inspired us to really move and address research issues that are topical. We thank all of you for being present, and the many people who are still online. We thank everybody, because if you didn't sign up to come, then we would be talking to ourselves. Miss Sally and the chairperson. So thank you for being thirsting for knowledge and signing up and coming, and then asking very pertinent questions. From some of the submissions, what I take from here for the next sessions, which is next year in November, we should try to look for a presenter on climate change and how it affects health, and localizing, putting it in the context of where we are. I think there is someone who asked about artificial intelligence, which is a real issue. It is coming up and people are using it. How are we using it in health? And if you have any other suggestions, you please fill out the post-meeting survey. And I don't know if the link has been shared for that, for the survey. Has it been shared? My neighbor here didn't have it. Let's share it and give us ideas on how we can make this more useful to all of us. Otherwise, this is to just say thank you to everyone, to the organizers, to the people who are streamlining us, and yeah, to Dr. Francis. He led the team and he's been here for 3 days. I had another meeting which was equally important. We were discussing 96-week results. Don't tell me what they are. I mean, don't ask me what they are. But yes, we had visitors from across Kenya, South Africa, Switzerland, but I knew that this was going very well anyway, so I joined online when I could. But thank you everyone for making this a success, and we shouldn't stop here and wait for the next meeting. For the nutrition, if you want to talk to us, there is a very vibrant nutrition advocate. You come and talk to us and see how we can work together. We do not want this to just end here and we wait for the next meeting. What do we take from these presentations? And we are different disciplines and everybody has different interests, but let's make this useful to us as we go back to our institutions. Thank you very much.
Wow. Please, let's add Dr. Sisi Anara. Yes. Thank you, Dr. Sisi, for wrapping up our discussion with such thoughtful comments. Your input has been invaluable. And to you, the audience, you've been with us 3 days. Thank you for enduring. Thank you for your attention. Thank you for your insightful questions. Thank you for your comments. And all your contribution has been appreciated. So see you next time. See you next year. Please put whatever we've discussed in practice. There's tea outside, the Motulekera. Thank you, and have a great evening, everybody. Please clap for me. We can have a group photo before you leave with the content experts. Yes, please come to the podium. You also get the opportunity to step on the podium. Scott.